Vikas Chandra Jha. Sir. Now, today's guest of honor is Dr. Sanjay Pandey, Professor Dr. Sanjay Pandey, who is Dean Research at AIIMS.Patna. I respectfully invite sir to the dais. Now invite our organizing chairperson, Professor Dr. Arun Agarwal, who is ex-Vice Chancellor of Aryabhatta University and currently HOD of Neurosurgery and President Bihar Neurosurgical Society. Now invite Dr. Rajiv Ranjan sir, who is Vice President of Bihar Neurosurgical Society. Now invite Professor Dr. Samrendrakumar Singh, who is Neurosurgery, Professor of Neurosurgery and HOD at IGIMS Patna and Vice President of Bihar Neurosurgical Society. Now invite Professor Dr. Paritosh Pandey sir, who is Secretary of Neurosurgical Society of India and currently working in Manipal Hospital in Bangalore. Now invite Professor Dr. Anitya Jagatia ma'am, who is Professor and HOD of Neurosurgery at GB Pant Hospital. Now invite Professor Dr. Deepak Kumar Singh, who is Professor and HOD at RML Hospital, Lucknow. Our invited guest faculty, Dr. Batuk Deora, is delayed and we are waiting for him. Facilitation. Now we would have the honor to facilitate our Dean Research Sir, Professor Dr. Sanjay Pandey. We'll next like to facilitate Professor Dr. Arun Kumar Agarwal, sir. Will next facilitate Professor Dr. Paritosh Pandey, sir. Will next facilitate Professor Dr. Anitya Jagatia, ma'am. Will next facilitate Professor Dr. Deepak Kumar Singh, sir. Will next felicitate Professor Dr. Rajiv Ranjan, sir. I would like to felicitate next Professor Dr. Samrendra, sir. Now we'll like to request everyone to please light the lamp and inaugurate. Welcome. What? Sir, I'll like to call upon Dr. Vikas Chandra Jha, sir, to
it is indeed a great pleasure and privilege for me to welcome you all for this august gathering, and I'm really thankful to our executive director and which is the chief guest, Professor Brigadier Raju Agarwal, sir, although he is not available presently because of some local engagements. Professor Sanjay Pandey, sir, our acting Dean Academics and Dean Research. Professor Agarwal, sir, who is the ex-Vice Chancellor of Aryabhatta University and President of the Bihar Neurosurgery Society. Professor Rajiv Ranjan, sir, Professor Samrendrakumar, sir, Professor Paritosh Pandey, sir, who is one of the torch bearer of the endovascular and bypass surgeries on which this workshop is focused, and he is the torch bearer of these technical aspects and role model for us. Professor Anitya Jagatia, which is a well-known figure and doesn't require any introduction from our part, Professor Deepak Singh, and Professor Batuk Debra, who is just going to join us here shortly. And I welcome you all for being present here and taking interest, and I hope that this workshop and this scientific session will be very helpful for the new neurosurgeons, and that will bridge the gap between the microsurgical, endovascular, endoscopic, minimal invasive surgery for management of the cerebrovascular disease as a comprehensive therapy. And I again welcome you all on this august occasion for being present here. Thank you.
Now we'd like to request everyone to please help us inaugurate this conference by lighting the lamp.
या कुन्देन्दु
I would like to request our guest of honor, Professor Dr. Sanjay Pandey, sir, to please say a few words.
A very good morning to all the respected dignitaries on the dais, Professor Arun Agarwal, sir, ex-Vice Chancellor, Aryabhatta Knowledge University of Bihar, Dr. and all the delegates who are from the different parts of the country here. Today, the Department of Neurosurgery is going to organize that CME and that is Neurosurgery updates. This is a most important event, and this kind of the event is usually very important for the younger generations to know the new innovations with the blessings of their seniors. And also it is a chance for the younger faculties, the residents, to give their ideas, whatever coming in their mind, the new innovations they can put before the seniors and get the suggestions. So this CME has already focused on the various things, and nowadays the neurosurgery speciality has advanced too much, and keeping in our day-to-day busy life, the change in our lifestyle, the incidence of the diseases related to the neurosurgical microvascular or conditions has been drastically increased. And the role of the neurosurgeons are very important to save the life. Just if we can imagine just 30 years, 40 years back, there was a very less number of people who were expertise in the neurosurgery. And also the survival was very less. Now the number has increased, and also there was a much advancement in the technology and the wisdom. So this all leads to the survival of the human being, and your services are also for the humanity. I congratulate to the Department of the Neurosurgery AIIMS Patna that all faculties, all the residents, they are working very hard. They are trying to establish this department at the best of their way. And every year they are doing lots of research-related activities, innovations, and the patent, in AIIMS Patna, the number of patents are maximum from the Department of Neurosurgery. And every year this figure is in the double digit. So this shows the hard work, sincerity of all members of the department, and organizing this CME at AIIMS Patna is naturally going to benefit the residents, the upcoming neurosurgeons, to enhance their knowledge, to enhance their skill. And with all these, I just congratulate to the Department of the Neurosurgery AIIMS Patna to organizing this, and I wish you all will return with the lots of the knowledge and the things for which you all have came here. And I wish all success of this CME and conference here very much. Thank you.
I would like to request Professor Dr. Batuk Deora sir to kindly come on the stage. He is our invited faculty. He is a professor in Department of Neurosurgery at LTM Medical College and Sion Hospital, Mumbai. Good morning. I would take this opportunity to felicitate Batuk Deora sir. Next, I would like to call upon Professor Dr. Arun Kumar Agarwal sir, who is organizing chairperson of this conference, to please say a few words.
Thank you very much, Rahul. Professor Dr. Sanjay Pandit, Dean Academics, AIIMS, Patna, the faculty and senior members sitting on the dais and off the dais. Today is not the formal inauguration. Professor Vikas Chandra Jha ka Paitur hai. Tomorrow is the real, but still, it's a great pleasure to come here, and I would love to tell you that the 2 days that are coming will be time for you to challenge your perspectives and to elevate your craft in contact with the great masters in the field of neurovascular surgery. And let's enjoy these 2 days, let's celebrate the feast, and let's celebrate the festival. And as President, I will put in a couple of words only, that 25 years ago, 20 years ago, we started this society as only 2 or 3, maybe 4 members. Dr. S.M. Rohatgi is one of them. And now today there are more than 100 people registered in this society, thanks to the very, very untiring efforts of Dr. Professor Samrendrakumar Singh. Let's enjoy these 2 days. Let's learn. Thank you very much.
I would like to call Professor Dr. Paritosh Pandey sir to please say a few words.
मंच पर बैठे मुख्य अतिथिगण, मेरे शिक्षक और साथी, न्यूरोलॉजिकल सोसाइटी ऑफ इंडिया के सचिव होने के नाते सबसे पहले मैं न्यूरोवैस्कुलर अपडेट के आयोजकों को हार्दिक शुभकामनाएं देता हूं। आज से हम इस अपडेट में विचारों का और अनुभवों का आदान प्रदान करेंगे, और इस आदान प्रदान के कारण हम साथ साथ आगे बढ़ने का प्रयत्न करेंगे, जैसे हमारी हमेशा से परंपरा रही है। न्यूरोवैस्कुलर सर्जरी आज एक दोराहे पे है। पुरानी परंपराएं टूट रही हैं और नई परंपराएं आगे बढ़ रही हैं। आज न्यूरोसर्जन अगर इन उपचारों में प्रशिक्षित नहीं हुए तो ये विभाग न्यूरोवैस्कुलर सर्जरी हमारे हाथ से निकल जाएगा, और निकलने की काफ़ी संभावनाएं हैं। मुझे बहुत गर्व है कि विकास और उनके टीम इस देश के कुछ एक डिपार्टमेंट्स में से हैं जहाँ पे ओपन और एंडोवैस्कुलर सर्जरी साथ साथ होता है और बहुत अच्छे तरह से होता है। और मुझे विश्वास है कि ऐसे अपडेट के माध्यम से हम और भी ज़्यादा युवा न्यूरोसर्जन्स को प्रेरित कर सकेंगे, जो कि न्यूरोवैस्कुलर सर्जरी के नई परंपराओं से और नई पद्धतियों से अवगत हो सकें। मैं फिर से विकास और बाकी आयोजकों का धन्यवाद देता हूं, और आशा करता हूं कि हम सब इस कॉन्फ्रेंस की वजह से कुछ ज्ञान प्राप्त करके ही जाएंगे। तथागत बुद्ध, महावीर और अशोक की नगरी में आने का अवसर बार बार मिले, यही हमारी तमन्ना है। धन्यवाद।
Next, I would like to call upon Professor Dr. Nitya Jagatia ma'am to please say a few words.
Namaste to all. I saw Vikas, like maybe Neurovascular Society, presenting on the endovascular treatment of aneurysms. And now I'm seeing this different Vikas with so much confidence and taking the team together. It is very essential to be hybrid. Because आप अगर ऐसे सोचें कि आप साइकिल चलाना जानते हैं, आप साइकिल पे जा रहे हैं, you're going by air also. अगर आप साइकिल का मज़ा ले सकते हैं, मतलब जब आप एयर में रहते हैं तो आपको पता लगता है साइकिल का मज़ा क्या है. और जब आप एयर में फंस जाते हैं तो भी आपको डेफिनेटली पता लगता है कि साइकिल क्या है, जो आपको हर तरह से नेविगेट करके यू कैन गो थ्रू योर वे. सो सिर्फ एंडोवैस्कुलर ही हमें नहीं सीखना है. वी नीड टू नो व्हाट इज़ ओपन, बट एट द सेम टाइम you cannot keep the endovascular away from your practice. जब आप दोनों चीज़ों को जानोगे, then only you realize what is good, what is not good. And over years, I think we can hybrid both open and endovascular in the same patient. So that may be the future. क्योंकि cost is very big aspect in endovascular. So I would suggest every new surgeon who is becoming the new surgeon, they should be exposed to both kind of modalities so that they can practice and they can judge, they can justify every treatment honestly. God bless us to be honest in our service. That is very essential. Only that will last for the longer time. Thank you very much and all the best to all.
Now I would have the honor to welcome Professor Dr. Ranjan sir to please address this gathering.
Good morning, respected faculty, distinguished guests, and dear colleagues. It is my great honor to welcome you all to this endovascular workshop as part of the Neurovascular Update Patna 2026. Neurovascular diseases are becoming more common and they require quick, precise, and advanced treatment. Endovascular techniques have changed the way we manage conditions like stroke, aneurysms, and vascular malformations. These procedures are less invasive, safer, and offer faster recovery for patients. This workshop is a valuable opportunity for all of us to learn, observe, and improve our skills. We have an excellent panel of experts who will share their knowledge, experience, and practical tips. I encourage everyone to actively participate, ask questions, and make the most of this session. Learning in medicine never stops, especially in a field that is evolving as rapidly as neurovascular interventions. Workshops like this helps us stay updated and improve patients' care. I would like to thank the organizing team for their hard work, mainly Dr. Vikas Chandra Jha and his team in putting together this academic event. I also extend my gratitude to all the speakers and participants for being here today. With this, I wish you all a very productive and enriching session. Thank you.
Next, I would like to call upon our invited guest faculty, Dr. Kumar Singh, who is Professor and HOD at RML Hospital.
Respected dignitaries on the dais, dear friends and colleagues. First, I would like to congratulate Vikas for, organizing this update and taking personal care of every one of us. मुझे लगता है कि this is only AIIMS in all across the India, including the AIIMS Delhi, जहाँ पे micro neurosurgery and endovascular neurosurgery both are happening today. I don't think any other AIIMS is doing both of these things, and this is happening just because of the personal effort of Dr. Vikas Chandra Jha. He has done many conferences in the past and is invited faculty across India in all, I think, all endovascular forums. And I am pretty sure with his efforts that at least in Bihar and this part of India, this technique or this type of, endovascular expertise, as Dr. Paitos sir has requested and has asked, will be recaptured by, the neurosurgeons. So I encourage you all, to engage in this, this session, this update, and thank you so much for calling me.
Now I'll have the honor to call Professor Dr. Batuk Deora, sir. Please address the gathering and say a few words.
Respected faculty members, friends, colleagues, I am very much thankful to Dr. Vikas for an invitation to participate in the neurovascular update. As a neurosurgeon, its time has already come. As a neurosurgeon, when we are interested in the endovascular neurosurgery understanding is inevitable and it is must. So if you are planning for making a career in vascular neurosurgery, understanding the endovascular neurosurgery is must. We all know about the number of vascular cases, the number of strokes, and there is a spectrum of vascular disorders we are coming across has significantly increased. And if we know as a neurosurgeon, we have a unique opportunity actually. We can manage these patients either surgically as well as interventionally, because many a type interventionist can manage these patients, but unfortunately in conditions like complications happens, then they cannot do anything. So as a neurosurgeon, we have a unique opportunity, and I think those vascular neurosurgeons should take an opportunity and learn both the things. Now when because many young neurosurgeons are interested in making or pursuing their career in the vascular neurosurgery, but the main problem is the training. So training in endovascular neurosurgery as well as training in microvascular neurosurgery is must. And the institute like here, AIIMS.Patna, where Dr. Vikas Jha has started endovascular neurosurgery as well as the microneurosurgery is must like. In Mumbai, we have a facility of biplanar DSM machine in almost all the teaching hospitals under neurosurgical care directly. AIIMS is the only institute where the endovascular facility is available under neurosurgery, and the rest all AIIMS endovascular is available with the radiologists. So we should push via the society as well. All the neurosurgery departments should have a facility of not even biplanar, but at least a facility for the digital subtraction angiography. So we can plan our cases, we can treat our vascular patients accordingly. Not all microneurosurgery and not all for endovascular. So with this, I again thankful to the Dr. Vikas Jha and entire committee for inviting me, and looking forward to you all and take a participation in the workshop as well as the meeting. Thank you.
Now I would like to call Dr. Samrendra sir, who is the co-organizing chairperson. He will deliver a vote of thanks to this gathering.
Good morning. On behalf of Bihar Neurosurgery Society, I must welcome and very thankful that so many faculties from the outside Bihar, they came and just to give some incitement about the endovascular things. So I already Dr. Vikas has told that they are very much inspiration for the young, our neuro team to indulge into the endovascular system. So many stalwart like Dr. Paritosh Pandey, Dr. Batuk Deora, Dr. Anita Jagatia, Dr. Deepak Kumar Singh, and our Bihar Neurosurgery Society President Dr. A.K. Agarwal, Vice President Dr. Rajiv, and especially Dr. Vikas has just taken the initiative to start the endovascular in the Bihar, and I think it's so much in infancy stage, but it's reached up to some heights. It's, I think, around 4 to 5 years back, the endovascular things started in the AIIMS, and now it's reached on the heights. I remember that around 10 years back, I was in the Medanta, Gurgaon, and the ACH patient traveling by road with the ambulance to reach the Delhi for the treatment. You can't imagine that subarachnoid hemorrhage. Should we keep on the sedation stage so that there should be no rebleeding? But unfortunately, at that time, our infrastructure and initiative not taken, but now it's very much thankful to start from the AIIMS, Dr. Vikas Chandra Jha. And it's growing now in the IGIMS also. We are starting in the PMCH, we will start. So gradually it's evolving, but this endovascular update can some stimulation to the young generation also. And it's not the choice to just take this initiative. It's a foundation because the patient, many patients came to the EU and to ask that we will not operate, we should go to the endovascular treatment. So the future is in this, and we have to take the initiative. For that, we have formed the Bihar Neurosurgery Society, around hundreds neurosurgeon in the Bihar. So first time Bihar Neurosurgery Society formed, and now it will be regular update about the advanced neurosurgery. So I must thanks to audience participants and our stalwart faculty that came here to the just giving some fire to the endovascular treatment. Thank you.
Thank you, sir. Now we'll ask all the chairpersons to kindly take their seats, and we'll begin with our first session. Thank you, everyone. Hello everyone. So we'll begin our scientific program for the day. So I would like to call upon the chairperson for the first session. I will request Dr. Arun Kumar Agarwal sir, Dr. Sanjay Kumar sir and Dr. Samrendrakumar Singh sir. I also request moderators for this session, Dr. Saraj Kumar Singh sir, Dr. Ambush Kumar sir and Dr. Brajesh sir to please come upon the stage. I would like to felicitate the chairperson and the moderators for the session. Now we'll begin our first session of this academic extravaganza, and I would like to request everyone to please stick to the time. We have a very limited time. There will be a timer, which will be, first trigger will be at the 12 minutes and followed by at the 15 minutes. So I would like to request Dr. Vivek Saran Sinha, who will deliver a lecture on the cerebral and angioanatomy.
Dr. Vivek Chandra Jha is an assistant professor in the Department of Neurosurgery at AIIMS.Patna, and he is one of the best best hands, along with Dr. Vikas Chandra Jha. Go ahead, Vivek. Let's see what you say.
Thank you, sir. Thank you so much for the introduction. And I would like to start my session on cerebral angioanatomy. And don't wasting our time, we will start with our first slide, the arch. Everyone wants to do the DSA, but knowing about the arteries is very important. What we are seeing on the DSA is very important. The first thing which after cannulation of the femoral artery, what we see by reaching by the Picard is the arch. The arch consists of the brachiocephalic trunk on the left, on the right side, a left common carotid and a left side subclavian. So from the left subclavian arises the vertebral artery. The left common carotid is independent, and the right vertebral artery arises from the brachiocephalic trunk, and the left right common carotid arises from the brachiocephalic trunk. There are various types of the arches, and most difficult one is the type 3 arch, which can be cannulated by SIM1 or SIM2 catheters, and it has a more steep and is difficult to cannulate. These are the different variations of the aortic arch. The bovine arch is the most difficult to cannulate, what I personally experience. And in the bovine arch, the brachiocephalic trunk has origin for the right common carotid and the left common carotid both. And along with it, the left subclavian gives branch of the vertebral artery. So cannulating this is very difficult as it is very steep, and moving SIM catheter up is very important to know. Now coming to the ICA and the ECA. So bifurcation occurs mostly at the C3, C4 level, and the bifurcation mostly can be appreciated by the mandible also. And the internal carotid artery is posterolateral, and the external carotid artery is the anteromedial. And external carotid artery, what we see here, has different branches. And external carotid artery also anatomy is very important to as some of the vessels go to supply some AVMs, and embolization can be done through this also. And the first branch is the superior thyroid. Second branch, what we see is the lingual. Third is the facial artery. And this is the ascending pharyngeal artery, 6th number. 5th is the occipital artery. And this is the middle meningeal artery. This is superficial temporal artery. And it continues as a maxillary artery. So coming to the ICA, which is mostly we cannulate. The ICA consists of 7 different segments, which is most typically described by Botherian roadmap. First segment is the cervical segment. Second is petrous. Third is lacerum, cavernous, clinoid, ophthalmic, and communicating. All we know this about. So there are the cervical segment does not give any branch and continues from bifurcation and travels along the cervical vertebrae, and from bifurcation till entrance into the skull, and it passes through the carotid canal. And it is a straight segment, almost straight in majority of the patients. And after entering into the canal, this segment goes into the petrous part of the temporal bone through the carotid canal, and gives off 2 branches, the caroticotympanic and the median artery. The caroticotympanic artery mostly supplies the middle ear, and mostly it is not visible in the DSA, but in some cases of like jugular tumors and tumors of the ear canal, these can be appreciated, and median artery passes through the median canal, and here we can appreciate the median canal which is present in the temporal bone. So third segment is the lacerum segment, and this segment runs over the lacerum, foramen lacerum, and runs till the PLL, that is the petrolingual ligament, and it is found by the occipital, temporal, and sphenoid bone. And this does not give any branch. So here we can see the fourth segment, that is the cavernous segment. The cavernous segment passes through the cavernous sinus and runs from the posterior lingual ligament to the proximal dural ring, and gives off 2 branches, the meningohypophyseal trunk and the inferolateral trunk. The meningohypophyseal trunk further divides into 3 branches, the dorsal meningeal, inferior hypophyseal, and the tentorial branches of artery of Vernus coni and carcinari, and inferolateral trunk. And then further going up, we come to the other segment, which is the clinoid segment, which is a very short segment and runs from proximal dural ring to the distal dural ring. And it is medial to the anterior clinoid process of the sphenoid bone and does not give any branch. The ophthalmic segment is the 6th segment, running from the distal dural ring to the PCOM, and it gives off 2 branches, the ophthalmic artery, and other is the superior hypophyseal artery. And then the last segment, what we can see here is the superior hypophyseal artery aneurysm. So mostly this is the location of superficial hypophyseal artery. The 7th segment is the communicating segment, and it gives off 2 branches, the PCOM and the anterior choroidal, and then further dividing into 2 branches, the ACA and the MCA. This diagram shows this is the presence of ophthalmic artery, this is the presence of the posterior communicating, this is the anterior anterior choroidal artery. So these are the different roadmap of the segments of the ICA. Now coming to the ACA, the ACA mostly divided into 5 segments. The first one is the pre-communicating segment, A1, then the A2 is the post-communicating segment, third is the pre-callosal or the A3 segment, fourth is the supracallosal and post-callosal A5 segment. The first segment, which extends from the bifurcation till it forms the anterior communicating region, and it gives off 2 branches. The medial lenticulostriate arteries arises from the A1 segment, and then other is the ACOM artery, which can be considered as a bifurcation or communication between the 2 ACAs. The second segment is the post-communicating segment, and the post-communicating segment is present from GNU till the GNU, and it gives off recurrent artery of Hubner and runs parallel to the A1, which can be seen in this picture. This is the recurrent artery of Hubner arising from the A2, and then further goes to give supply to the medial orbital frontal artery, and then give rise to the medial frontal orbital artery arises from the A2, which can be seen here, medial frontal, and then the inferomedial frontal, which supplies the inferomedial frontal lobe, and the frontopolar artery, which arises from the A2 and supplying the frontal pole. And the third segment is the A3 segment, or the pericallosal artery, and then through the pericallosal arises the callosomarginal artery. The pericallosal artery runs over the corpus callosum, which is a very important structure in the segment division of the ACA. And then this callosomarginal artery give rise to the pericallosal artery, give rise to the different branches like anteromedial, interomediofrontal branch, posteromedial branch, paracentral branch, and then the last segment give rise to the singular branch. So here we can appreciate different branches. This is the frontopolar or bitofrontal branch, and then this is the callosomarginal artery, this is pericallosal artery, and this callosomarginal artery give rise to different branches which supplies the frontal lobe of the brain. Now coming to the MCA. The MCA comprises of the 4 segments. And these segments are the sphenoidal segment, the insular segment, opercular segment, and the cortical segment. From the bifurcation, it is the M1 segment, and the M1 segment give rise to arteries which are divided into superior and inferior branches further, M1, and then M1 till division and superior inferior division of the till the form give arteries to the insula also. So these are the different hair-like vessels which are present in the M1 segment. These are the lenticulostriate perforators supplying the basal ganglia region. And then further, this M2 segment, and then M2 and M3 segments are closely related to the insula. And this M3 segment then runs in the sylvian sulcus between the parietal and temporal opercula. And then M4 comes out and runs over the surface. These M4 segments give rise to the artery of prefrontal sulcus, artery of the post-central sulcus, central sulcus, and then angular arteries. And further, these are supplied over the surface of the brain. And from the M1 segment also arises the lateral frontobasal artery and the anterior temporal arteries. So here we can see the M1, M2, M3, M4 segments. These are the first segment of the lenticulostriate arteries which are present from the M1 segment. and then anterior temporal artery and polar temporal arteries arising from the M1 segment. M2 and M3 segments are closely related to the insular. M4 segments then further divides into different arteries of prefrontal, frontal, precentral, central, and postcentral sulcus arteries. So this is the close relation of the M2, M3 segments of the MCA with the insula. And then these vessels are closely related, are embedded in the sylvian fissure and comes out to form the M4 segment or the cortical segment, and supplying the frontal, parietal, and temporal lobes. And frontal perfusion and the motor, premotor, motor, and somatosensory area are supplied by these arteries. And parietal also supplied by some parietal branches and the angular artery. And then temporal perfusion also occur by the temporo-occipital branch and middle and posterior temporal branches. And M4 is the cortical branches, which covers almost all the lobes of the brain and very important artery. So this is the angiographic depiction of the MCA. Now coming to the posterior circulation. So this is formed by mostly the two vertebral arteries forming the basilar artery and then dividing into terminal branches of the PCA. So the vertebral artery arises from the subclavian artery, and then from the C6 till C2 level it is present, and then curves around the C1 to form and joins to form the basilar artery. The basilar artery gives rise to the different V1 segment and V2, V3 and V4 segment of the vertebral artery. This is the different subclavian origin and then running of the vertebral artery into the foramen transversarum. And then further this arches around the C1 and then enters into the skull base. And then through the skull base, the first segment, V4 segment gives rise to two posterior spinal artery and one anterior spinal artery. The posterior spinal arteries run till the conus medullaris, and the anterior spinal runs till the sacrum. And then further it divides into different pontine arteries. The lower one is the posterior and inferior cerebellar artery, and then other branches are labyrinthine arteries, which are present in the from the basilar arteries, and through the from the PCA, superior cerebellar artery also arises from the top of just below the PCA, and then supplies the cerebellum and the other perforating vessels supplying the brainstem. So these are the different angiographic depiction of this vessel. So finally summing up, this is the vertebral artery, the anterior inferior cerebellar artery. The perforating arteries arises from here, superior cerebellar arteries arising here we can see, and then dividing into terminal PCA branches. So I will not go into details of the PCA, and some venous system I want to include. The superior sagittal sinus, these are the superior venous system, the vein of Labe, vein of Trollard. These cavernous sinus draining into the sigmoid sinus through the inferior petrosal and into the transverse sinus to the superior petrosal. And then in the internal cerebral vein joined to form the vein of Galen, straight sinus, and draining into the confluence, and then further draining into the transverse sinus, sigmoid sinus, and then into the internal jugular vein. Thank you so much. Thank you.
Try to cover everything in such a short time. So, do we have the questions from the audience? Do we have the mics there? And then comments from the moderators too.
Very nice presentation, Dr. Vivek. All the aspects of cerebral angioanatomy has been covered beautifully in very short time. Although the variations which are of great clinical importance are missing because of probably time constraint. Yes. So hopefully we will learn and listen those things in our next talks. Great.
Thank you so much, sir. And thank you for providing me this opportunity to open the session. Thank you so much.
Thank you very much, Dr. Vivek Sharan Sinha. Now I call upon Dr. Professor Batuk Diwara, who is the Professor, Department of, I'm very sorry. Now I call upon Dr. Professor Deepak Kumar Singh. He was a professor and head of the Department of RML Hospital, Lucknow, to present his paper on cerebral DSA step by step. Professor Deepak Kumar Singh, sir.
So thank you once again for calling me and giving this opportunity, respected chairpersons. So digital subtraction angiography. We have to okay. Okay, so what is angiography? Angiography is basically the study of vessels after putting up the contrast. And what is subtraction? Subtraction in simple Hindi is ghatana. So what you do, you just subtract the fluoroscopic images, the bone images from the images in which the contrast is there. So you get only the images of the opacified vessels. So that is subtraction. And what is digital subtraction angiography? Digital subtraction angiography is the acquisition of that opacified vessel imaging in the real time. That is the digital subtraction imaging. And on the right side, you can see that is the DSA machine of our lab, biplane cath lab of Canon. And coming to history, it was first, the angiography technique was first invented by Egas Moniz, who was a Nobel Prize winner. And then the idea of the subtraction was first introduced by Plantus in 1935. And by that time, they were using, all the cannulated needles and the pointed catheters for taking up the angiographic images. But the Seldinger technique that was devised in 1953, that had changed the scenario, and everything has become very safe. So indications are endless, and with time, as you become more and more experienced, you will realize that the indication and therapeutic, indication of diagnostic and therapeutic work is actually endless. So be it SAH for aneurysm, pseudoaneurysm, thrombosis, it is actually endless. And I am learning, the new indication day by day. There are newer things like CSF hypertension, CSF venous fistula that are also coming into the treatment part right now. So indications are endless, and when you become experienced enough, you'll realize that in a neurosurgery practice, you can use this DSA and therapeutic things in lot of procedures. So contraindications are not that much. I particularly don't find there is any absolute contraindication. Deranged coagulation is actually contraindication for surgery, but for endovascular work also with deranged coagulation, you can perform some work by a bit correction of the coagulation profile. And allergy to contrast media, you can change the contrast media, you can dilute the contrast media, or you can ask your medicine team to be at a standby if you are feeling that it can create a problem. Poor renal reserve, there are some problem in patients who are actually in nephropathy, but there are techniques in which you can do safe angiography in patients with poor renal reserve also. You can do pre-dialysis, and after that, after the performing your procedure, you can immediately put patients for post-angiographic dialysis. So it is safe, and contraindications are not there as far as this work is considered. And plan, this is actually important. You have to review the previous studies and examine and mark all the peripheral pulses before. Because after performing the procedure, if you are going to check your dorsalis pedis, then it can be a problem. Maybe it was not there before. So what I have seen that people have a habit of marking the peripheral pulses after the procedure, or checking the peripheral pulses after the procedure. So when you start, you should always mark your peripheral pulses before the procedure, whether it was present before or not, and then only you can be absolutely sure that you may have created some problem. If you have not marked it before, then doing it after is, not that conclusive. And always plan the study for what indication you are actually going to do it. So for giant or serpentine aneurysms, for cavernous aneurysm, in which you may require a bypass procedure thereafter, you may not, be able to perform the endovascular therapeutic thing. So in that cases, you may require the patient to post for bypass procedures, and in that cases, you want to see what is there with the external carotid system. So you get a good idea. So or for AVM or dural vascular diseases who have been subjected before to surgery or who have been bled and came to you after so many months when there is a gliosis, there are chances that there are dural recruitment of the cicatrized AVM, and in that cases getting a picture of the external carotid system is equally important. So always plan the study and what you exactly want to look for. So this is the machine, the DSA machine. So if you are planning for a biplane, so there are many vendors like Siemens, G. What we have is Toshiba, Canon, and Allinger is in the market with monoplane machine. There are some good CIAMS also, like of AIIMS, Philips, and Euro Columbus. But the problem with the CIAMS is that they are not, of good kilowattage. So these three CIAMS, AIIMS, Philips, and Euro Columbus has come into the market with 20 kilowatt generator. And with that, you can do a very good angiographic work similar to a cath lab. The problem is only the 3D reconstruction of images. That is not possible with these CIAMS. But if you have money, you always go for a cath lab. If you don't, always try to have at least 20 kilowatt generator CIAM. So this is the picture of our lab, and this is one thing that is very important. Always choose a very good lead apron or lead-free radioprotective apron for your vascular work, and we use 2-piece because it distributes the weight on your shoulders and the waist. And always go check the thickness of your lead, what you are using for. For dental work, it is like 0.2 to 0.25 mm. So when you buy it, they give you aprons that have a very thick lead or very thick lead-free protectant there. But for all angio work, the thickness of lead should be more than 2 mm. That you should remember, that you should specifically ask that this lead apron is approved for angiographic work or not, because this is important. For dental work, it is only 0.2 mm. For all angiographic work, it should be more than 2 mm. And never forget to order your head cap and the neck cap, neck shield. So workstation, coming to workstation, when you are planning to buy, always buy at least 2 angiographic workstations apart from one that is inside your cath lab. Because when your residents or when your colleague is taking an angiographic run inside and you want to study what is happening, what has happened before in the previous run, you have to ask him to stop the work. So it's absolute that you should have as much as workstations as possible, at least 3 workstations outside and 1 inside is always there, but minimum of 3 workstations outside is absolutely necessary. We have 2 only, and we are facing a lot of problem because when you want to study what has happened in the previous run, so we have to ask our colleagues or our residents to stop taking the fluoroscopic images, then only we can check what has happened in the previous run. So at least 3 workstations. And materials, you need to have a lot of things inside, that is arterial sheath, catheters, guide wires, contrast, different type of connectors, heparin, protamine, nimodipine, saline, pressure bags, different type of bandages, and liver lock syringes. This picture is, very famous, and you can find it in every endovascular book. But for practical purposes, for cranial work, our go-to catheter is H1, SIM1, 2, and VERT. And for all spinal work, we prefer to use Cobra and SIM2. So that is the least amount of catheters, minimum number of catheters that you want to have into your setup. Now we have started using NY MPC for most of our work. So these 6 or 7 catheters you require for, and that is sufficient enough for doing all the procedures. So contrast media, I will not go into detail, but nowadays for most of our work, we are using iohexol, that is low osmolar contrast medium, and the iso-osmolar contrast. Initially, it was actually like high osmolar and low osmolar, and that by that time, VGPAC was not into market. So they got a problem that what to name it. So they named it iso-osmolar, but it's actually high osmolar, low osmolar, and very low osmolar. So VGPAC is slightly costlier, but its osmolarity is the best for all angiographic work. But you can use OmniPack if the renal reserve is good, or this UltraVist. So for good renal reserve, you can use OmniPack or UltraVist. For poor renal reserve, you have to use iso-osmolar like VGPAC, slightly costlier. So a basic rule to check for the dose of contrast media is, you should take the weight of the patient and multiply by 5 for an adult, and for child you have to multiply it with 4 and divide it by serum creatinine. So you get a rough idea of contrast that you can use for any particular work. And then you have to see that the phase of distribution is 30 minutes and elimination is 2 hours. So almost half of the contrast is out of the system in 1.5 hours to 2 hours. So you can actually use more and more contrast, but for most practical work for an average patient who is having creatinine of 1 and 60 kg, 300 ml contrast you can use safely. So these are different type of catheters. Preparation is same as for a routine neurosurgical work. Only important thing is that you should mark all the peripheral pulses before going for the procedure. Patient should be well hydrated, because if it is not well hydrated, you may face difficulty while palpating the pulses at the start of your procedure. Informed consent is must, and patient should always be shifted on a trolley. So procedure is basically you can divide into different steps: gaining arterial access, then arch navigation, selective arterial catheterization, image acquisition, and then hardware removal, closure of arterial access if you have that sort of money, and post-procedural care. So I'll directly go to this is the trolley preparation. You need to have a lot of bowls and lever lock syringes, tubings, saline. Air is the biggest enemy during your diagnostic work. This is how we position and prepare the patient. We always prefer to, prepare both the groins, because you may face difficulty while puncturing one side, so you should make it a practice to prepare both sides of the groin. And this is the puncture site. So two finger breadths below mid-inguinal point is the ideal puncture site. And if you have any difficulty, you should always remember that puncture site is almost 1 centimeter medial to the center of the head of the femur. So that you also can see. And the femoral puncture technique there are different puncture techniques have been described, but we are very simple in our access. We just puncture the femoral artery, and if there is an arterial gust that is coming outside, we pass the J wire, we remove the puncture needle, and over the dilator we pass the arterial sheath. There is, in the literature it has been described that you should puncture both the walls, then withdraw, but we don't follow it now with this J wire. This J wire is very safe. So radial artery access is similarly, you can take the radial artery access, and this is prevalent. This is being done by cardiologists a lot, but for us, since we are using bigger devices and bigger catheters, then femoral puncture is still is very common, and doing everything by femoral route. And this is how you perform. Can you run this video? भैया ये वाली वीडियो चलाओ. यहाँ पे एक्सेस नहीं है इसका वीडियो रन करने का. Okay, so this is how you remove the air from your system. Okay, air is the biggest enemy. You must understand this, and water is your biggest friend. रहीमन पानी रखिए, हर जगह पानी ही पानी होना चाहिए. Then only you can avoid the complications. ठीक है. And this video is available on the, Neurology India website. The step-by-step technique, you can go through it. Please play the video. इसको play कर दीजिए. Let me do it, okay? So these are different type of catheters. Okay, so a little bit about the arch. So the type 1 arches, all the arterial origin is at the same level. You can say that is type 1. Type 2 is when you take the diameter of the CCA and it is 1 to 2 diameter. The brachiocephalic origin has been shifted a little bit down. So this is type 2, and type 3, if the difference in the origin of brachiocephalic and the top of the arch aorta is more than 2 diameter of the CCA, that is type 3. So for type 1, H1 catheter is good enough, and it can be simply calibrated by any of the catheter, type 1. But for type 2 and type 3, you need to use your SIM1 or SIM2 catheters, the sidewinder catheters, because it is difficult to calibrate it with the simple arch catheters. And I will directly go into the video. It is only 2 minutes video. Okay, see how you have to take the puncture. At 45 degree, you feel the pulsation between two fingers and you do the puncture. Okay, there is arterial gush that is coming, and then you put your J wire, and over that J wire, you remove the needle, and with dilator, you put your arterial sheath. I will take 2 minutes, sir, only. Okay, then you check that free flow of blood is coming, and then you connect the hypernized saline, you fix the arterial sheath, then you prepare your catheter, you remove all the air from inside by opening all the valves, and then you introduce your, this is Invire deck that was used for therapeutic work. Over the wire, you introduce it. There is a sheath also that you can use for putting up your catheter. And this is how your catheter goes in the aorta and aortic arch. You should always keep a length of wire ahead of your catheter. And it has hooked the brachiocephalic. Now it is going to the common carotid. Take a run and then navigate your catheter into the ICA. For all the diagnostic work, you need not to go beyond the cervical part of the ICA. You take your run and then come out, go into the ECA. Again, based on your previous roadmap, take a ECA run. Then you withdraw your catheter, go into the subclavian, hook the vertebral artery. For vertebral angiogram, you need not to go more than 1 centimeter beyond the orifice. Take your vertebral run. Then you withdraw your catheter, keeping its head up by a counterclockwise rotation, and it will engage all the arteries one by one. And similarly, you can take run of your left side system. So you can go through the details in the already available video on the Neurology India website. Then if you have difficulty, always use a micropuncture kit. And if you are doing into LA, the common habit is that people infiltrate over the artery. And that is the problem, because the nerves, if you remember what we have studied in the BDC, it is nerve from lateral to medial, nerve, artery and the vein. So if you see, the femoral nerve and the cutaneous branches are coming from lateral to the medial. So you have to infiltrate a good amount of anesthetic agent, local anesthetics, lateral to the artery. That you should always remember. And always label your syringes, make it a habit. It's like a mathematical equation, you know. You follow the same procedure again and again, and your cath lab and your all the assistant will become familiar enough to perform the same procedures again and again without any difficulty. And always wipe your wires after every subsequent dilator. And we don't reverse the heparin as a routine. If necessary, you can with use of protamine. Complications can happen like local and systemic complications, but it's very rare. And post-procedural care, only important thing is that you have to ask for patient to take a bed rest for 4 to 6 hours, and you should check the vital signs and peripheral pulses. So one important thing, if you don't have that biplane facility, what you can do, because you need to see the working angle. So when we didn't have that, the biplane lab in our department, what we have done, we have paste this, this chart in our cath lab, where you can actually always know which part of artery is best seen in what type of projection. Okay, so if you are like, want to see vertebral artery origin, it is best seen in Townend and Waterview. But you cannot remember all these things every time. So we have pasted this in our cath lab, and that helped us a lot. But now with availability of biplane cath lab, it is not required. So thank you so much.
Thank you, Dr. Deepak, for trying to make it a bit more simpler than it seems to be. But I think this is a good eye-opener for the youngsters who would like to venture out into this endovascular field. And moderators, any questions? Any comments? Vijesh? And audience also would like to make it a bit interactive. Yeah,
Hello.
Dr. Anita.
Hello. A very nice,
Hello.
nice presentation, sir. I want to, sir, know, sir, how to know, sir, we have reached the arch.
How to?
How to know, sir, we have reached the arch, and sir, which side we have to go? Arch, sir. How to know we reached the arch?
So it's not that difficult actually. I mean, you know, the turn of catheter, you know, the fluoroscopic images, you can always check the, I mean, the vertebras, where the arch is taking, you know, your turn at the T4. So it's not that difficult, you know. And if you are, I mean, cannot see where is the origin of the vessels and you feel difficulty in navigating, you know, the subclavians and the brachiocephalic, you can take a pigtail catheter and you can give dye to take an arch aortogram, and accordingly you can see the orifices of different vessels. So it's not that difficult. You can always see that you are not going straight, you are turning up. So if you are turning, your catheter is turning towards the left, you obviously is going into the arch of aorta.
So for taking, say, arch aortogram, do we need some other dye or?
No, similar dye, but you may need to take a different pigtail catheter. It has, you know, multiple holes on the top. So with little amount of dye, you can see the origin of different vessels.
Dr. Anita, please.
Yeah, want to add one more thing. So if you are thinking of arch, ideally you should have this, otherwise also you have CT angiogram. So CT angiography, when you are prescribing, you should add that you should have the arch angiogram also. That will decide your catheter also. That way you can plan your catheter, which catheter you want to take. One thing. Second thing is, if you want to, your wire is always going ahead of the catheter. So your wire will definitely go in towards the arch because its shape is bent, it is bent. So it will always take the shape of the arch, as Dr. Deepak said that it is at that level of D4. So that anatomy we need to know that where the arch would be. And you can replace all the dyes with a Visipig, which is a low vascular, which is safe for the renal and everybody. Even the cardiologists have switched. We have learned lots of angiography and DSA procedures from cardiologists. So whenever you have the time, go to the cardiology lab and see what all things they are using. So it is always good that we are still learning from the cardiologist. So I want to add one more thing, Dr. Deep.
Yes, sir.
I think you told or you missed. If you keep a monitor in your console room for the anesthesia people also.
Yes, obviously.
That's a good idea because otherwise they'll be exposed to a lot of radiation.
It's a part of procedure actually. Yeah. So it's not only a single, we have 3 monitors, but since, you know, the monitor things belongs to anesthesiologist, so I have not mentioned it because they always ask for, and you can always add up more and more monitors. Monitors you can add, but this, the working monitor, that you cannot add later on because it's very costly. So
you should add in your specs only.
You have to
monitor in your
yes. Vital monitor is very cheap. You can always add, but this working monitor you cannot add. It is very costly. So you should always make a part of a specification.
Sir, what is your bolus dose of heparin for therapeutic and diagnostic procedure?
What is
bolus dose of heparin? How much heparin dose?
Okay, so for all diagnostic work, 1000 unit of heparin in 1 liter of saline. And when you are going for a therapeutic procedure, so you have to give 5000 of heparin stat, and you should always check the ACT. So we try to keep ACT always more than 2 times during the procedure.
And you add after checking ACT or repeat hourly?
So as I have mentioned, the elimination time, you should check the ACT at every 2 hours, 1.5 to 2 hours.
And how do you choose between SIM1 and SIM2 catheter for bovine or type 3 arch?
For all type 2 and type 3, SIM is actually good. But the problem of SIM in India is that it's only available in 5 French. We don't have 6 French SIM catheters. So, it may be available in some centers, but in our center, 6 French SIM is not available. So the problem is that you need to, if you want to go inside, you have to always so I come to your question first, then I'll go to this. So with experience, you actually get to know after taking the angiogram that your H1 catheter is going in the left side system or not. That you will learn with experience. But most of time, even in difficult arches, you can hook the left side system with SIM2, most of time. So if you feel what is happening with advancing age, the elastin fibers that are holding up the arch of aorta, they get loosened up. And there is increase in the collagens inside the aorta. So it elongates. The arch, the ascending aorta actually elongates, and then why at the young age, the arch of aorta has like a candy cane appearance. And with the advancing age, it has become like a question mark. So if you are doing angiogram in any patient who is more than like 50 years of age, then you should always suspect that you are going to have some trouble. Okay, so be prepared with your SIM2 catheters if you are doing angiogram in an old patient, always.
Thank you, Dr. Deepak.
Thank you so much, sir. Yeah. Thank you. Thank you once again, Vikas.
Can I call Dr. Batuk Deora? He's a professor in Sine Hospital, Mumbai, and now he'll be throwing some light on how to select your hardware for the endovascular procedures when you're trying to set up your DSA facilities in your hospital.
Thank you, Chairpersons. At the outset, I would like to thank Dr. Vikas for an opportunity. So, as we have discussed earlier, the cerebral angiography is the prerequisite for any neurointervention procedure. So, when we talk about the hardware selection for the endovascular procedure, before that we should know about what are the endovascular procedures to be available for the various cerebrovascular disorders, and what are hardwares available. Then and then you can choose. So I will be like sharing various endovascular procedures, hardwares in a short time of maybe around 20 minutes. Before that, I would like to invite you all for 9th Masin Congress that will be held in the month of May 14 to 17 in Mumbai. And this will be the last time Dr. Majid Sami will be in India. So make an opportunity and please join us for this Masin meeting. So endovascular procedures are the procedures being performed inside the vessels, maybe within the artery or the vein, or sometimes inside the both. These are the minimal invasive procedure under local anesthesia or the general anesthesia, and for the various brain and the spinal pathologies, and always require the fluoroscopic guidance. Dr. Deepak discuss about this fluoroscopic labs. So any procedure for the cerebrovascular disorders we perform through the vessels, that is called endovascular neurosurgical procedures. We have two different type of procedures. One is a diagnostic procedure for the brain, that is called a cerebral angiogram. For the spine, it is called a spinal angiogram. And then we have a therapeutic procedure for various brain and spinal disorders. If we see the spectrum, we have various spectrum of cerebrovascular disorders that includes the aneurysms, AVM, atherosclerotic narrowing of the arteries, outside the cranium and inside the cranium, dural artery venous fistula, commonly carotid cavernous fistula, major venous sinus occlusion or a narrowing, many times the vascular tumors like a glomus jugulare and meningioma. And so often now we are also having an opportunity to treat hydrocephalus using endovascular treatment and the chronic subdural hematoma using endovascular techniques. Like either of this is okay. If the biplanar machine is there, that is the best thing to perform this procedures. The advantage of biplanar is like you can have a same injection, you can have an AP and little images. So when we think about the endovascular procedures, we need to have this sort of tools, or you can say the equipments or various in your armamentarium that includes the needle, sheath, various catheters. We are having a variety of catheters. Then we have wires, we have stents, we have flow diverters, we have intrasecular devices, we are having embolic agents and coil retrievers devices. I will just briefly introduce I will be little fast because otherwise I will not able to cover. So when we talk about the needles, this is the most important thing. When we talk about the needle, we always talk in the gauge, like the larger the gauge, wider the needle. When we talk about the catheter and sheath, we always talk about the French unit. And when we talk about the wire, that is always in a inch. So we have a 4 French to up to 9 French sheath available. And we have 0.038, you can say 038 to 008 size wire available in our endovascular armamentarium. Needles, we have seen the previous presentation, direct puncture of the needle in the one wall puncture, but in a pediatric patient, sometimes we do the dual wall puncture. We are having a variety of the sheath. Sheath is to take care of the guide catheter or any other distal access catheter and the microcatheter. We don't require to remove the access repeatedly, so that's the purpose of sheath. And for 4 French and 5 French angiography sheath, we mainly use for the angiography, maybe spinal angiography or a cerebral angiography, while the rest of this sheath we mainly use for the endovascular procedure purpose. So we have an angiography catheter. We have a discussion in detail about these are actually the tubes and the variety of catheters available. Commonly we use the words H1 and the SIM1 catheters. And these catheters comes in the different sizes, shape, and their hydrophilic properties. So one of the catheter, like for the aortic arch angiogram, this is a pigtail catheter. We put at the ascending aorta and inject the contrast around 26, and then we can have a complete arch of aorta. Guiding catheters are required for the endovascular procedures. Once you decide there is an aneurysm and you want to coil the aneurysm, you have to reach to the aneurysm via microcatheter, distal access catheter, and the proximal, that is a guiding catheter. So guiding catheter is like a proximal support. Higher the support proximally, you can go more distally inside the intracranial circulation. And always, like, you have a good access, then your procedure will be successful. We have a variety of guide catheters, like commonly used is the Cordis, like Envoy, and from the Cook, like Shuttle Flex. Along with that, there are the spectrum of guide catheter. Also, we have the commonly and relatively cheap Fubuki catheter. Then we have a cavernous Serinovus catheter for the J&J. Once you come across these products, then and then you will have an idea about where to use what. Once you put the guide catheter in the proximal internal carotid artery or the distal carotid artery, then you again take a support of the distal access catheter. So they are relatively soft catheters that can go up to the middle cerebral artery distally or sometimes in the supraclavicular ICA. And then through these catheters, again, we have different sizes of the catheters, different length of the catheters, and through this catheter you can navigate the intracranial pathology, maybe aneurysm or intracranial stenosis. So this cartoon shows how various catheter. Up to here we can use either a sheath or the guiding catheter, then we can use the distal intermediate catheter, and then for the intracranial procedures like aneurysm coiling or the embolization, we use a microcatheters. Commonly used sheath is the Neuron Max long sheath or a catheter, and is having a larger inner diameter. When we think about endovascular procedures, we always have to consider about the inner diameter of the catheters, that is always in an inch. And this is having a highest, you can say the 088 is the highest inner diameter catheter, so we can use for these various endovascular procedures. After that, this is the, so you know about the angiography catheter, now you know about the guiding catheter, then we have an intermediate catheter, then we have a microcatheter. Microcatheter are the very small catheter that delivers the material, that delivers the coil, that delivers the embolization material, that delivers the particles. And there are a variety of microcatheters available in the market. But one thing you have to remember is the coiling catheters. Coiling catheter always having 2 different markers at the distance of 3 centimeters, and your coil has to coincide with the proximal marker of the coil marker has to coincide with the proximal marker of the microcatheter. And there are catheters without these markers, mainly used for the delivery of the embolic materials. So these are the microcatheters from the Cordman. This Select Plus is used for the delivery of the intracranial stent, and this is used for the embolization of the aneurysm. Again, this is a microcatheter from the different company, Microvention, Headway 21, commonly used for a variety of endovascular procedures. Some catheters are flow directed and detachable, so mainly during the embolization of the AVMs or dural AV fistula, we can detach some distal part of the microcatheter, so that is called a detachable catheter, and they can be directed with the help of the just injection of the saline, so that is the reason they are called a flow directed catheters. This is the microcatheter from the BALD, that is the smallest microcatheter. Distal tip is the 1.2 French, and that is mainly used for the distal, you can say dural AV fistula or the artery venous malformation. So after this, we have an aspiration catheter. These are the different type of the catheters being used for the mechanical thrombectomy. That this catheter aspirate, they are having a different properties, like they are relatively soft. You can bring to the supraclavicular ICA sometime up to the origin of the middle cerebral artery or into, you can say, the M2 segment, and you can suck out the clot through this soft catheter. So this is the principle. Here you just put the tip of your catheter proximal to the clot and provide aspiration through either a syringe or the suction pump available in the market, and these are called the aspiration catheters. Again, like we have a variety of aspiration catheter from the different companies. Once you start using it, then you will come to know about the various properties of this catheter slide. After aspiration catheter, we have balloon catheters. There are catheters having a balloon at the tip. So what are these catheters? So these are the balloon catheters having a tip, balloon at the tip, and there are different properties of this balloon. They are a non-compliant balloon, there are compliant balloon, there are super compliant balloon. These super compliant balloons are mainly used for the embolization of the, you can say, the balloon assisted coiling of the either in the bifurcation aneurysm or the side wall aneurysm, while this compliant balloon used for the atherosclerotic disease. Again, like this is a variety of balloons, hyperform balloon they take the shape of, sometimes the shape of the vessels. So this is a hyperform balloon for the endovascular coiling, balloon assisted coiling. These are the different sort of balloons from the different company, and this is a Copernic balloon used for the embolization of the dural AV fistula. These are again the very small balloon, these are a single luminal balloon or a double luminal balloon, and these are used for the balloon assisted coiling or sometimes the balloon assisted injection of the embolic materials. So this cartoon shows how the balloon assisted coiling is being performed. You inflate first you gel the microcatheter inside the aneurysm, then inflate the balloon, and then slowly fill the aneurysm with the coils, and finally you deflate this balloon. So this is called a balloon assisted coiling. There are different balloons used for the thrombectomy purpose. Once you aspirate the clot, so we have a balloon guide catheter. So you put the balloon guide catheter in the neck, in the proximal carotid, internal carotid, or the distal carotid artery. While removing the clot, you just inflate the balloon. So there will not be any forward flow of blood, and then you cannot have a fragmented clot that can go distally. So these are the balloon guide catheter mainly used for the stroke thrombectomies. Wires, we are having a different sort of wires. Commonly used wire are the angiography wire that already discussed in the previous discussion. But the commonest wire we use is the Terumo 035 wire. I mentioned about those various sizes. These are different wires with hydrophilic properties. Usually we use hydrophilic wires compared to the non-hydrophilic wires. Like these are stiff wires. So these wires are used for the guiding the angiographic catheter to go inside. We cannot take this angiographic catheters beyond the petrous ICA. One should avoid taking these wires beyond the petrous ICA. So these are various shape and sizes. Then we have micro wires. Micro wires are the one that takes the microcatheters deep into the intracranial circulations. So we have a variety of microcatheters, and this microcatheter delivers the material. Microcatheter delivers the aneurysm coils. Microcatheter delivers a PVA particle, embolic materials like NBCA or Onyx. So these are the purpose of the microcatheter. Sorry, I'm extremely sorry. We are talking about the wires. So these microcatheters are being taken on the wires, and various sizes we are having available is like smallest is 008. So for the 1.2 French angiographic microcatheter, we use 008 wire, and for routinely we use 014 wire for the aneurysm coiling. So there are various properties one has to learn about this, about the wire. Commonly used wire, microwire is the Traxxas. And then we have a stands. We are in different sort of materials being used for the various purposes, like for the carotid, we have a carotid stand. We have a detailed lecture on the carotid stand, so I will discuss during this time. We have now intracranial stands available for the atherosclerotic disease as well as the stent-assisted coilings. And this is one of the Neuroform at last. We use open cell design for this purpose. We have a stent for the mechanical thrombectomies, like a stent-like device is being used for the thrombectomy. So for the thrombectomy, we have two devices. One is the aspiration, direct aspiration, and second is stent-like devices. That is called a stent retrievers. Again, we have a variety of stent retriever available in the market. Whatever you are comfortable, you can best use in a given patient. Then we have flow diverters. When the flow diverters came into the market, they are actually the stent-like devices, but that covers almost 30-35% of the neck area. So in a way that diverts the flow from in the parent artery. So when they came in the market, we thought like this is the magic treatment for the aneurysms, but ultimately we, over a period of time, we realized they are not the final treatment for the aneurysms. Like. So the principal use is to put this flow diverter across the neck of the aneurysm, and slowly that aneurysm will get thrombus over a period of 6 months to 1 year. And again, like we are having a variety of flow diverters available in the market, and you should know about how to deploy the flow diverter. Then we have intrasaccular devices. These are mainly for the bifurcation aneurysms. Again, like when these devices came into the market, we also thought about this is it's like ultimate treatment, but unfortunately, this aneurysm closing rate was not comparable with the aneurysm clipping. Again, these are the different devices that is called a neck stent and the contour device. These are the saucer shaped devices that has to be kept at the neck of the aneurysm, and these are based for the bifurcation aneurysms. Then we have embolic agents. We have a variety of embolic agents. Mainly we use PVA particles and coils. Coils, you should know about the details of the coils. It is made of the platinum wires, and there are primary wires, secondary wind, and primary wind, and the secondary wind. It's available in the variety of shape and the sizes, and these are the 3D coils and the helical coils. We have embolic agents with us. Is a cyanoacrylate that is relatively cheap, but it's immediately solidified in compared to the ethylene vinyl alcohol that is called onyx. It slowly percolates within the venous arteriovenous malformation or the dural fistula. So this is available from the Medtronic. Then we have a polyvinyl alcohol particles that is mainly used for the tumor embolizations. And finally, we should have about the coil retrievers device with us, because many times we have a dislodgement of the coil. This device can help us. This I will show some of the example like this. So this is a simple coiling. You put the coil inside the aneurysm with a narrow neck. This is the base side scenario. The mid-basilar small neck aneurysm that was treated with the endovascular just coiling only. This is the ICA bifurcation that was treated with the simple coiling without any. This is the middle cerebral artery. Middle cerebral artery base is the microsurgical clipping, but many times patient family demands, so this was suitable for the plain clipping, plain coiling. Then this is the basilar tip aneurysm. Always when you have to see the opening of both the PCA, your coil should not come beneath this thing. Then and then you can use this coiling method for the embolization. Here again the PCA, left PCA aneurysm that was treated with the coil embolization only. Then there is a wide neck aneurysm. So wide neck aneurysms, we have two options. Either we use a balloon. So this was a ACOM aneurysm that was treated with the balloons. And this was again like partly treated with using a balloon, but unfortunately there was a significant neck remnant. And the other option is a stent. When there is no space for the coil to hold at the neck, we use a stent-assisted coiling. And again, you can see this, the stent is placed first, and then through this the stent strut, we pass the coil. So this was a PCOM aneurysm treated with the stent-assisted coiling. Again, like the ophthalmic artery that was treated with the stent-assisted coiling. Then the flow diverter. I have discussed about the flow diverters. Flow diverter usually for the small, we don't put any sort of coils, but the large and giant many times require the placement of the coil. So this was a cavernous petrous cavernous carotid opposite wall aneurysm that was treated with the flow diverter. Only 6 months follow-up, you can't see any significant reduction of this aneurysm size. This was again like the cavernous carotid symptomatic. There is only indications for the symptomatic cavernous carotid. One should always be like, because this aneurysm doesn't rupture. So there is only symptomatic cavernous carotid aneurysm should be treated. So again, this patient was treated with the flow diverter, and the 6 months follow-up, you can't see any aneurysms. Mid-basilar dissecting aneurysm, giant aneurysm that was treated with this flow diverter. Here you can see this method are so beautiful, like over a period of time, you don't feel like there's some sort of pathology was there in particular segment of the artery. So fusiform aneurysm, ideal for the stent-assisted flow diverter. This is one such in the posterior circulation aneurysm. Web devices, I have mentioned about this. These devices are relatively costly also, and many times one has to be decised properly while using these devices. This was again a case of traumatic pseudoaneurysm in the neck, because the neck, there is no, in the neck ICA, there is no branches, so we can put a covered stent. So in this patient, we put a covered stent across the neck of the aneurysm, and aneurysm disappears. AVMs are, we know about the variety treatment options available for the AVMs, and the microsurgery is the best in 1 or 2 and some of the cases of grade 3. But there is a role of endovascular embolizations, and we using a microcatheter either with the NBCA or Onyx, we embolize these AVMs. In a case of when you plan for a microsurgery, some feeders are not easily accessible, and then you can plan for a previous embolization. This was a case of a vein of galenic malformation that was treated with the embolization. Carotid stenosis is a spectrum of disease like, again, like that can be treated with the endovascular treatment in a high-risk patients. And now we know the CREST trials, and many asymptomatic patients being treated with the endovascular treatment. So you first do the angioplasty, and then put a stent across the disease segment. Intracranial artery disease, there is a clear-cut indications when patients fail with the dual antiplatelets medication, then and then one has to think about, because these procedures are risky. So one such case of middle cerebral artery aneurysm, that was middle cerebral artery stenosis, that was treated with the stent, and supracranial ICA stenosis that was treated with the stent. This was a proximal basilar stenosis that was treated with the stent. Sir, 1 minute. Mechanical thrombectomy, I have discussed in about the various material available. I have one such case of the IC occlusion that was treated with the aspiration catheter and the device. There is a role of endovascular treatment in the cortical venous sinus thrombosis. One can see there is no sinus here. After thrombectomy, you can see there is a complete opening of the sinus. Dural AV fistula, again, like many of these patients are mainly treated with the endovascular treatment rather than the microsurgery, and the carotid cavernous fistula. Mainly we use embolic material. Here is coils. This was a case of the coiling of CCF via inferior petrosal approach. Dural AV fistula, again, like this was a falcine dural AV fistula that was treated using an endovascular treatment. You can see that there is no AV fistula. Venous sinus stenting is one more option for endovascular treatment. Here you can see there is a stenosis of the sinus, and that was treated with the stent. This was the wall stent. And tumor embolization, like as I mentioned, we use a PVA particle for these patients. And finally, as a neurosurgeon, we also should be aware about what is happening about hydrocephalus, because now we have a in a future, maybe we'll have an endovascular treatment of the hydrocephalus, where the shunt device will be, E-shunt will be placed through the inferior petrosal sinus into the subarachnoid space, and we all know about the role of chronic subdural hematoma embolization role. So as I was mentioning previously, like there is one should have a train in both endovascular and micro neurosurgical training. And AIIMS, that is a minimal invasive center in Mumbai, where we are keeping a course on endovascular neurosurgery and the microvascular neurosurgery every 3 months. So these are the models. If you can just see that these are the models. These are the tissue models we have indigenously manufactured there, and we are keeping a regular training for endovascular as well as the microsurgical training. And last time I had an opportunity to invite Dr. Vikas Jha for endovascular workshop in Mumbai. With this, I thank you all. Thank you.
Thank you very much, Professor Batuk Deora, for this very vast and comprehensive but very clear understanding and explanation of these endovascular procedures, DSA. I would request questions from the audience. Moderators, want to ask?
Sir, what will be your preferred sequence of catheters for a simple narrow neck PCOM aneurysm and second DACA aneurysm in a 70-year-old patient?
See, nowadays we use a triaxial system. So usually we use a Neuron Max, Navian, and then the microcatheter. And in the elderly patients, like a vessels will be tortuous, so always better to have a triaxial system in these patients.
Microcatheter, which microcatheter you prefer, sir?
We use a Echelon microcatheter. I prefer Echelon microcatheter.
Okay, for DACA as well, you go
yes,
for...
Yes, yes.
Okay.
Thank you, Professor Bhattukdera. I now request the Master, Dr. Professor Paritosh Pandey, the Secretary of the NSI and from the Manipal Hospitals, Bangalore, to teach us something more about stroke intervention. Professor Pandey.
Thank you, sir. Thank you, Vikas and team, for this kind invitation. Right. So whenever we talked about cerebrovascular surgery or endovascular surgery for the last many years, there has been a clamor of treating aneurysms, and we have all seen all these useless clip versus coil, which Vikas also has put it in program and everything. And the whole focus is on hemorrhagic diseases, and those are what, 10% of the strokes, out of which aneurysmal subarachnoid hemorrhage is probably 2% of all strokes. And here is a place where the ischemic strokes are 85% of all strokes here. I always tell my fellows or residents that in this new era of endovascular surgery, they should learn 4 things only, and their bread, butter, and jam and everything is completely secured. One is DSA, other is carotid stent, for which Bhattuk will speak. Another is mechanical thrombectomy for stroke. And the 4th is embolization of the chronic subdural hematoma. If somebody knows these 4 procedures, they will be much richer and much happier than all the other endovascular surgeons who are going to treat all these complex things that Bhattuk said, web device and this and that. Who has the money for all these things? Anyways, the role of neurosurgery in acute ischemic stroke just a few years back was decompressive hemicraniectomy, and that is one of the most depressing procedures that you can ever do in your life. And this also brings in cranioplasty, which is probably a procedure which has 100% complication. Like if you follow them long enough, everybody will have one complication or the other. Wound infection, this, that, here, there. Carotid endarterectomy, and then refer the patient to it. Now, what has happened for last 10-15 years is that this is a patient of 34-year-old male. Stroke is at 8:30. He has right hemiplegia, aphasia. He reaches hospital in the night when you are ready to sleep. And this is the imaging, and this is small stroke, and this is a small stroke, and the MC is occluded. And everybody knows here that just a few years back, this young man with complete life ahead of him, he would have had a large stroke, he would have had a decompressive craniectomy, he would be bed-bound or dependent on ADL for his entire life, for the life that he is going to lead. Now what we do, we go ahead, take a groin puncture, revascularize. This is MC occlusion, this has become normal, but that is not the end of the story. This is the post-op scan. What is the story is that he is normal. He is walking, he walks, he does his work, he does his everything. And that kind of treatment is very rare in neurosurgery. you think amongst yourself, how many patients make this dramatic improvement? Probably EDH, chronic subdural probably, if with a large midline shift, and mechanical thrombectomy for stroke. Only these many. Rest of it is we are just firefighting here and there. And of course, here a PFO and things like that. So acute ischemic stroke has already had an evolution. Mechanical thrombectomy or aspiration is the now standard of care. Till 2015, we had evidence for IV TPA, but very poor recanalization for large vessel occlusion. Good outcomes for only 30% of the patients. And these were thrombectomy devices which were very, very poor. I mean, anybody who has used all these thrombectomy devices like Mercy device, I don't know whether people have worked it or not, very poor devices. Then came this trial, and along with that, then came 9 other trials in very, very quick succession. And everything showed that mechanical thrombectomy for stroke for large vessel occlusion is twice as good as giving only the medical treatment. This is the crux of the matter. So anywhere if you see the MRS 2 to 3, if there is medical therapy is 25, then mechanical thrombectomy will be 50%, will be MRS 0 to 2, and so on. So these are all there. This is the basic absolute risk reduction and number needed to treat, and we'll come to that. There have been meta-analysis which have been proved that to reduce disability by 1 level of MRS, you need to treat only 2 patients, 2 or 3 patients. It is that good. What has changed? We have better devices. We have better pathways in the things. We realize that we don't have to ponder upon things. The most important thing that we don't have to wait for the IV TPA to work for revascularizing. So a lot of neurologists had this conception that if patient does not improve from IV TPA, then we will send patients to them. That's not the thing. We must revascularization as soon as possible. And this has come in on the guidelines. We have this workflow which has been tried and tested for the STEMI, so we are not reinventing the wheel. Everybody knows how every ER knows how a STEMI works. The same pathway is there for us as well, except the fact that we have to go through a couple of imagings, and the STEMI only has to go through some ECG. And this is the evidence. More and more people are now doing mechanical thrombectomy. How effective is MT? For 1 point, MRS improvement is 2.6. For functional independence, it's 4 to 6. And number needed to treat for coronary for STEMI death, you have to treat 50 patients of STEMI to prevent 1 death, and repeat MI is 25. So it is that effective. It is probably one of the most lowest number needed to treat procedures in the entire thing, apart from defibrillator for acute cardiac death. So this is the effectiveness of this. Age is no criteria. More the NIH, more the benefit. You should have time to recanalization as minimum, but that does not mean you just do whatever you can. You should take care of the safety, because one of the most common complication is bleed, and that completely ruins the process. Optimization of imaging, and there was a debate about GA versus LA, but nowadays we always use GA because 10 minutes doesn't make a difference, and the procedure is much easier, much faster, everything. Now we have extension of indication. We have larger strokes. In larger strokes, and we'll come to that, vessel occlusion with minimal symptoms, distal occlusion in stents, and we'll go through all these things. So we have already extended the window to 24 hours and sometimes much beyond. So if the patient does not have any major stroke on CT or MRI and the vessel is occluded, we have opened up the vessel for as late as 3 days for the thing, because these procedures are very, very safe nowadays. So Dawn trial was there in selected patients. The functional independence was 49% in thrombectomy group versus 13% in medical treatment. But of course, this is not saying that this is death of time in brain. Faster the recanalization, better the results. And this is done we will come to how we do these procedures. MEVO, which is called medium vessel, anything beyond M1 ICA basilar is still not proven, but in some of the proximal M2 occlusion especially on the left side, especially on the dominant M2, we go ahead and do these procedures. The 3 trials that came for MEVO were all negative. And a major problem with MEVO is that because of the tortuosity of the vessels, there is an increased incidence of bleeding in these things. And probably it needs a little more better hardware, a different hardware, so that we can go ahead to do thrombectomy in different kind of things. Large core infarcts is a big thing. I'm not very convinced by the data that exists here. But at least for a large core stroke with aspects 3 to 5, there is a decent role. For 0 to 3, probably there is a very little role in my view. But the shift is towards doing the large core strokes as well. What will you do when you have a very low NIH and a blocked artery? And that is something that comes very, very often to us. But we have to see whether to do this or not. And there are trials which are going on for these things. A lot of times we still, after talking to the patients, we still go ahead and open up the artery if we think that it is quite safe. Posterior circulation strokes were not a part of all these landmark trials, but this was one of the few very easily openable arteries. So you can just aspirate those clots. It's a straight artery. There is no cavernous there. The first few trials were all negative, but now we have 2 trials, one from the US, another from China, which shows that from up to 24 hours, if there is no big pontine or bigger strokes, the patients who received mechanical thrombectomy do better than these things, and these images are quite easy to get. So this is the clot, and these are the vessels here. How to achieve? There are 2 ways. Initially, most of the trials were done by stent reverse, which is basically a stent which captures the clot and then takes it out. So you have to remember that almost all of these strokes are embolic strokes, and vessels itself is not diseased unless there is an underlying ICAD. So you don't have to put a stent there. You just have to put a temporary stent and capture the clot and do this. And this is a video, but I will just skip it here. You just have to put this stent here. This captures the thing, and then you take out the entire thing. As soon as you put a stent, actually you start the flow here. And there are many things that you can do this. Nowadays, my go-to thing is to do aspiration. So aspiration, there are very, very good catheters now which can go without a microcatheter support till the ICA or MCA, and these are cheaper devices as well. You get 068 devices, 071 devices, 072 devices, and almost 2/3 of this thing are easily revascularized with only one aspiration. And you have to just put it there. We don't even use this kind of pump, even though there is a lot of research regarding cyclical or continuous pressure. We just aspirate with a 50 cc device, a 50 cc syringe, and I'll tell you, in almost 2/3 of the patient, it revascularizes by its own. And if it does not, then we have to use other things. So we have shifted to an aspiration first in this, but it has been studied that aspiration versus stent reverse, and there is really no difference here. The results at 90 days are difference, and with aspiration, you obviously get a faster revascularization. IV TPA in LVO, whether to do it or not, all that we know is that it is the people who get IV TPA, if they are on time window, have better results than people who don't get it. Sometimes we have to do stenting, both in the carotid and this, and the research has shown that rescue stenting has a better result than if you don't put. So initially we were very, very reluctant for putting stents, but now we are very free in putting stent, and an open vessel is better than a closed vessel. So if you have such a scenario where there is an underlying carotid stenosis and occlusion later, you go ahead and balloon it here, revascularize it in distally with whatever you see that we are using only one suction device which is there, and that has opened up the entire vessel. When we come down, there is still this stenosis. This is very likely to again close or throw up thrombus upstairs. So we load them on aspirin or clopidogrel, or you can give a GP2B3A blocker tirofiban with a blocker for 12 hours and place a carotid stent. And the same thing we have done in many patients with underlying ICAD, and we have found that an open vessel is generally much better than the closed vessel. Of course, you have a chance of reperfusion, bleed, and thing. The main thing here is the blood pressure. If you maintain the blood pressure at very critical range, then most of these patients do fairly well and or do this. There are times when we have not done it, and these are times when we balloon angioplasty these patients and wait for half an hour and see whether it is closing or not, and we don't put a stent, and we do a carotid endarterectomy a couple of days back. But generally now our preference is to put a stent if there is a critical stenosis or tandem occlusion here. So now the evidence is not in a doubt. The EVT in LVO is a standard of care. What are the challenges? The main challenge, I think, is the education of the medical professionals as well. Almost nobody in the outside this hall or outside the community of neurology and neurosurgery are aware of this procedure. Patients will always go to the next hospital, whatever is there, within 1 hour of their onset of stroke. It's not possible that somebody has aphasia and hemiplegia and they don't go to the nearby hospital. What happens in that nearby hospital is what decides where you will be there. If you reach a hospital which is stroke ready, which has all these things, then you walk out. If you reach a hospital which does not, then you became hemiplegic, and that becomes a very problem. And of course, this should be a fillip to establishment of stroke centers, and there is evidence that patients who are taken to MT-enabled stroke centers have better results. More and more neurosurgeons must get trained in at least mechanical thrombectomy of strokes. Otherwise, there are other people who are very happy to do these, including the cardiologists who have been reperfusing the heart for a very long time. We should have quicker recanalization, so that's why we do aspiration first and then stent reverse. Some people do everything at once. Some people take a aspiration device, stent reverse, Solumbra technique at once. But this, at least in my view, it is a wastage of resources. We probably are still using a very disparate amount of imaging techniques. Some people use MRI, some people use CT angiogram, some people use this. I think there is a time that it should be standardized and we should use one kind of procedures. Of course, there is AI, but really rapid AI, we did not find it very. And I'll leave with these two patients. This is a patient of endometrial CA, left hemiplegia dysarthria. She came to ER. Door to needle time was 45 minutes. Door to recanalization time was 65 minutes. MRI, of course, showed right MCA infarct. We woke up in the middle of the night, right M1 occlusion. Post thrombectomy, she became totally normal, and she was normal. And this is her scan. This is a scan in this scan in the ER. This is this MRI which was done. Our people still prefer this. This is the M1 occlusion. This is M1 occlusion on table, and after some time we can recanalize this. And what is important is her post-op CT looks as good or as bad as the previous one. So she walked out of the hospital. And there is this another patient who was 57-year-old male, known case of cervical dystonia. He had 2 episodes of TIA. He gave us time in 7-8. And all these things is happening in the hospital, which is probably big hospital in Bangalore. Again, TIA recovered again, neurologically normal. MRI was done. MR angiogram could not be done. Shifted to ICU. He worsened at 3 a.m. And by the time MRI and MR angiogram was done, it was 10 a.m. And it was a mistake. Complete IC occlusion, hemispheric infarct. And I'll show you the images. He came with this image. And then at 10 a.m. when we had this, he had a big stroke. And of course, you know the destiny of this patient. He will either die or be ideal all over. And this is the scan. So this is the level of difference that is present in patients who get this procedure versus the patients who don't get this procedure. And that is why I say that LVO with AIS in neurosurgical terms is the new extradural hematoma. You have to throw everything, stop everything, run and open up the vessel just as we ran and took out these blades. It's a surgical disease. It's one of the most effective procedures that exists in the armamentarium of the neurology, actually the entire physician community. Good patient selection and decompressive hemicraniectomy should completely go to the relic of the past, and nobody should do it for acute ischemic stroke. Every patient should have the benefit of this large number, and that is why I would request the new neurosurgical community to at least learn these 4 procedures that I have said, so that you can give benefit to the patient in the community. With these words, thank you very much for your training.
Thank you, Dr. Parthosh. That was really wonderful with a good message. One thing I would like to know, seen a couple of cases like this when there was, I wouldn't say it was over-enthusiastic attempt for thrombectomy, but what is your comment upon the reperfusion injury? Because many cases I have seen some neurosurgeons doing that.
Yeah, I mean, in a large core infarct it happens. I'm sure there is a very large, if there is a large core, which there is already a very large infarct there, and if you open up the vessel or if you do carotid stenting in those patients, there is very, very high chance of reperfusion injury unless you do a very, very strict monitoring of blood pressure. But in smaller core infarcts, generally, it is not there. You have to remember that IV TPA has 6% intracranial hemorrhage. So even IV TPA has 6% intracranial hemorrhage. So in patients, and various research has shown that the symptomatic intracranial hemorrhage is no different between the 2 groups. So MT plus IV TPA versus IV TPA in this thing. These days, as we are moving more and more towards aspiration, there is very little chance of patients having wire injury and other things like that. One place where there is really a very high chance of bleed is the smaller vessels thrombectomy, especially the MCA, M3 or M2 distal or M3, because these vessels are actually tortuous and there are perforators which are coming. So when we do these procedures, we will see that the blood vessel has stretched or has become straightened. And during those attempts, there is 1 or 2 perforators which get dislodged, which we don't see on the table, but next day we will see this. So that is probably one of these things, yes.
Actually, reperfusion injury will be more common if you are doing more than 6 to 12 hours actually. More than 6 to 12 hours. If
MRI, so that's the timing which is very important.
Yeah, timing, and second is we can see the, if MRI or CT, if you are seeing any mismatch. If mismatch, and third what sir is said is aspect score. If aspect score, definitely if it is less than 5, there will be reperfusion injury chances will be more. So just want to ask one question. As you are practicing private, what is the outcome if you are doing the re-exploration after 6 to 8 hours? I mean thrombectomy after 6 hours. Outcome, sir. You are considering only time or any mismatch and depends on the aspect score?
So we completely go on whether there is a large infarct or not. If there is a large infarct, we don't do these thrombectomies. Only if there is a decent amount of brain to save, and we don't do very fancy imaging, I don't believe in all these things. There is a very, very nice acronym which is there, 3, 6, 24. So 3 means your aspect score should be more than 3. 6 is NIH should be more than 6, and 24 is of course 24 hours. So if any patient falls in this 3, 6, 24 thing, go ahead and do this. More patients will benefit than will get harmed. Of course, 1 or 2 patients will get harmed of all these things. But if the patient...
Diffusion, whatever Dawn trial and diff is still going on, so 1, 2, 3 numbers as it's going on for
yeah.
6 to 12 for 24
yeah,
hours.
Yeah.
No, just revascularization injury will be the whatever outcome, and revascularization injury will be more common if mismatch or score, if it is DWI being increased, where if it is decreased, then will be good, sir. If it is not there, then revascularization will be, you are more harming the patient than the...
Right. So you can do perfusion imaging, and of all the trials, because they have to select a very tight number of patients, they do all these perfusion studies. But in general, as practically, if you have an occluded vessel at 10 hours and your MRI is not showing a very large amount of stroke on diffusion, you must go ahead and open up the vessel, and it will be almost same as Dawn trial or diffuse trial. If you, even if you don't have very fancy imaging. Of course, if you have fancy imaging, you can go ahead and show it in the conferences.
It's considered aspects or percentage?
Both aspects, which is more than 3, but I would say probably more than 5, and the core imaging, DWI core imaging less than 100. So these two criteria are there, but actually visually you can see that if there is an area to be saved or not. So visually, if you go ahead and do the MRI, you will know which is a large infarct and which is not a large infarct. We are not doing trials, we are not doing those kind of things.
Whatever my experience I have seen, the thrombectomy is done after 8 to 12 hours, always landed up with revascularization injury, hemorrhage, then decompression.
In medicine, there is nothing called never or nothing called always. Everything we are in between of these never and always. So what is always for you, it can be rare for some patient, but in general, if patient does not have a large core infarct, the revascular reperfusion injury does not have anything to do with the time itself. Why should it have? Logically speaking, why should a patient who has a larger infarct should have a larger stroke? Of course, flare, if there is a flare established stroke, they bleed more than flare non-established strokes. That's been shown even in IVTV trials. But that being said, opening the vessel will do more good than harm in many of these patients.
How would tenecteplase add to buying some more time before it goes to you?
So tenecteplase is a fantastic medicine, and we because you don't have to give it in a infusion, we can give it in a bolus. So most of the Indian neurologists or stroke centers have moved to tenecteplase, and if the patient comes in the first 4.5 hours, they must be given IV treatment, and if there is a large vessel occlusion, then shift it to the cath lab here. So of course it adds to the benefit, I think. It makes the clot softer. Of course, in many of these patients, 30% of the patients, you will have opening up of the blood vessel only with IV TPA. So that's fine, and that has probably been our experience as well.
Yeah, that's one important drug for most of the hospitals in our state at least, before they reach higher centers like yours.
Yeah.
Any moderators? So thank you very much.
Thank you, sir.
You are a master.
Anita, yeah, sorry.
C3 or 2B maybe, and 4-5 days patient is fine. And then suddenly 5th day or 6th day you see that there is deterioration and the spark is appearing now. What is your experience in the morning?
Yes, so reocclusion in the data, of course, has been there. Reocclusion happens in as large as 10% of the patients. So you can have reocclusion. You can have cardioembolic stroke, which has occluded the vessel once and which will occlude the same vessel or the other vessel later. So everything is possible. The primary pathology is not in the, most of the times, 90% of the times, it's not in the brain. The primary pathology is somewhere else. So the same pathology is still active despite our medical treatment, can again throw up a clot and say this. So if there is an atrial clot, and even if we are giving AF drugs and things like that, that can again go ahead and embolize it. So that's not something which is a criticism of this procedure. That is just the pathology of the brain which works like this way.
Not the procedure. So we need to follow them at least for maybe 5-7 days.
Oh yeah, of course.
We follow them so that they do not land up into the knee infarct. That is a big issue.
Yeah, of
we
course.
have been experiencing because Indian population is low in protein content.
Yeah.
And that is actually we have more strokes than the Western countries.
Sure. Yeah.
So we should think on.
Yeah, of course. And most of the patients will stay in the hospital for at least 1 week or something like that. So most of the reocclusions happen very early, but reocclusion is a real problem, and I agree with you. Yeah. Yeah.
Sir, I wanted to ask that is there any difference between the two things of aspirating a clot via syringe and aspirating the clot via the dedicated machine?
Aspiration of the clot via dedicated machine versus syringe. versus whatever suction device you have at your own place. In our experience, there is zero. So we have stopped using penumbra machines for last 5 years maybe, and we just aspirate with a 50 cc syringe, and that works. That being said, there is some research which is coming, and Penumbra has now a new type of suction machine which is called cyclical, where they aspirate and stop, aspirate and stop, aspirate and stop, and they say that it is better than this thing. We have not used it. I think it's a stretch.
Any pressure, how much pressure can you use?
No. So we just put it and put a mosquito artery forceps and leave it for 2 minutes. And that probably works for almost something. I can advise you, it's not a standard treatment. I can just say that we do this, but machine is fine. I mean, and machine you don't have to buy a actual machine penumbra machine. You can use your hospital suction machine, and there are plenty of them, and you can aspirate through this. There is no big science in aspirating here.
Suction machine, if you are using, what is the pressure we can use?
Which one?
Pressure.
I would know. I don't know. I have not used hospital suction machine, but yeah, not much.
No, you would have used the machine.
Penumbra?
Penumbra machine.
Full. We do full. Whatever is the full thing is there. But yeah, as I said, I don't use it. It's expensive. It's an expensive syringe, so it's not something that I like too much.
Last question: if there is a patient who has come to you in your center and already received IVTPA outside center, so patient has reached due after 6 hours of IVTPA, and the diffusion weighted MRA pre-IVTPA, and when it reaches your center, almost the similar, maybe mild increase. So you will go for mechanical thrombectomy, or you will hold?
If there is an LVO and if the patient's NIH is more than 6, yes, I will go for a mechanical thrombectomy.
Thanks.
Yes.
Yes, last question, please.
Sir, is there any role of STA-MCA bypass after 24 hours?
There is very limited role of STA-MCA bypass. We do this. We have done this a few times, especially in patients who have a stable stroke, where you know that the collaterals are not very good. So suppose the collaterals are coming from the ACA, they are slow, and patient does not have any big stroke. You can go ahead and do an STA-MCA bypass, but that X of the number of patients that you will treat in your lifetime for these STA-MCA bypasses is less than the number of patients that you will treat mechanical thrombectomy in 1 month. So these are very rare scenarios where you can do STA-MCA bypass. Of course, there can be no trial for these patients because the number is so small. But yes, there is a very small role in the limited time frame.
Can I do MT after 24 hours if there is no much harmful?
What our approach is, there is no evidence for this. Don't trial and everything is still 24 hours. What is our approach is, if you do an angiogram, and if your collaterals from the ACA goes ahead and very rapidly forms till the MCA. So you will see it going and almost forming till M2. Then we generally don't go ahead and see. If you see the collaterals coming, but they are slow in angiographic frame, then you can go ahead. And these are all very, very fluid indications, and there can be no good evidence on this. But you will know if you have treated a lot of diseases, which is a good collateral and which is the not so good collaterals. So if there is good collaterals which very rapidly comes on, reforms the MCA and the bifurcation, then generally it is good to leave all these things, because a large number of these things would be with ICAD itself. And that is why there is such a nice collateral here. So those things we don't do it. If there is not very good collaterals, you can give benefit of the doubt. Again, these patients are very, very rare. Most of these patients will form in that 3, 6, 24 thing, and you will be able to treat any of these things with available evidence.
Thank you very much, Professor Paritosh Pandey, for a masterly presentation. Thank you very much. I would now request Dr. Professor Anita Jageta, who is a professor and head of the Department of Neurosurgery at GB Pant Hospital, New Delhi, presenting a paper on aneurysm coiling step by step. Ma'am.
Yeah, good morning all. Thank you, chairpersons and Vikas and team for this opportunity. So, many things have been covered by many authors, many speakers in the previous sections. So, if I talk about G.V. Pant, we started endovascular under the leadership of Dr. A.K. Singh. Actually, his vision that it stays with the neurosurgeon since the beginning, and we started doing the. Actually, it was a domain of neurosurgeons only, because they were doing direct puncture during the times when we did not had CIMS. So these are the CIMS on which we were performing all the DSAs and actually procedures also. And recently, over last 3-4 years, we bought this Zyme CIM. So as Paritosh was saying that we should learn at least stroke, which should be done at the place where the patient has it. So even if you do not have good labs, which we have now, which was recently inaugurated also, no one can stop you for doing the endovascular procedures. So if we talk about coiling of the aneurysm, there are many steps. Of course, vascular access, then arch and vessel selection, understanding the aneurysm morphology, and thereafter you need to decide what is good, either the endovascular procedure, or that is a catheter-based procedure, or non-catheter procedures. So you need to have a good knowledge of hardware and coiling, as Batu told in detail. So we are familiar with our micro instruments. At the same time, you have to be familiar, very, very familiar with the hardware. That is a very essential aspect of any endovascular procedure, whether you say angiography or intervention. So after taking the access, which usually still we are taking the femoral access, however, people are trying with the radial access also. In difficult cases, where the arch is bad, where there's problem in the ascending aorta, then you can go for the brachial access or maybe direct puncture of the carotid as well. So when you are doing the femoral puncture, best way is palpatory method. Like we do put the lines at many places. So just 2 centimeters below the inguinal ligament, you see the femoral artery, palpate the femoral artery. You can take the help of C-arm. You can take the help of ultrasound also. C-arm has its own problems, or the lab has its own problems, which I'll talk about the radiation exposure. So minimize the radiation exposure as much as you can, because you are a neurosurgeon. You may not be doing only endovascular practice, you may be doing spine surgeries also. So you are not exposed to one radiation type, but you'll be exposed to many different procedures in the spine. So palpatory method, palpate it, put your femoral access, and thereafter, depending upon the arch, which you can read beforehand, before like CT angio, and then you can decide what hardware you want to reach to the target vessel. So these are the catheters which you may require actually if the vessels are bad. Otherwise, nowadays you have the catheters, you can make your system biaxial, triaxial. Initially, we used to exchange with the wire, long wire, and taking the guiding catheter. Now you can take that, you can decide that in the beginning. You may not require the diagnostic catheter exchanging it. So you can decide based upon the arch what hardware you are requiring. So, and the anatomy arch, which was told, like these are the 2 bad arches, which are bovine arches. Here definitely you will require SIM2. You may require many long sheath may fall, and all those things are the learning curves. And sometimes for this kind of arch where bovine and you are not able to go and take your catheter right high up, even if with all the kinds of different good hardwares today. So in these cases, you may require to do the direct puncture also. So after taking this shoot, keeping your catheter into the target vessel, maybe ICA, VA, or basilar, you go through this, your panel on the machine, that you have X-ray setting, collimation setting, C-arm filter. You need to know this all, collimation and all, which I'll talk later in the next lecture. So you based on the case, you put your angiographic picture into the roadmap phase, and Next thing is, so when you are going to the roadmap, means you are already femoral check flow is in, then your guiding is in. Check flow may be small check flow, it may be large sheath, large femoral sheath. Then inside there's guiding catheter, which is again taking one more catheter, that is micro catheter for coiling processes. So up to the check flow or the guiding, you are taking the shoots in the lumen of the catheters. But in my personal experience, never take the angiogram through the microcatheter. It is very risky. I have burned the fingers. People may have their good experiences, but even one bad experience is the lifelong lesson. So it is usually not required and should be avoided. Then you should understand the morphology of aneurysm, secular, fusiform, what type of hardware you will require, what type of procedure you want to do. So here is the after putting these for all the catheters, you have to be aware about the hemostatic valves, because hemostatic valves should be good. It should be snugly fit, properly checked, and these lines should be connected with the heparinase lines so they do not block and they do not cause complications. Your microcatheter, you may have pre-shaped, you may have to shape it based upon the morphology of the vessel where you are reaching. So there are many companies into this market. You should be aware about what all companies, and every company doesn't have all the hardware good. Few hardwares are good of one company, few of other company. So you should be knowing about this all. So before going and starting the coiling process, you should take a good view where you can separate all the vessels nearby, perforators, major branches. That should be understood, that should be noted, and position your C-arm in that particular angle, which you can take with your 3D, or if you do not have 3D, then in 2D, try to separate where best you can separate all the branches from the aneurysm neck. There are different types of coils, framing, filling, finishing coils, and maybe bioactive coils. So these are the part of hardware. There's only, based on this formula, you can only pack maximum 30 to 35% of the aneurysm which can be coiled. The rest of the things happen with the body mechanism. So what people say that coiling is 100% procedure, it is not true. It doesn't give 100% treatment at the very first go. So this was the angio which was done recently. This patient had very bad arch, tried a lot, but we were not able to take the catheter in with all kind of things available. So we did this direct puncture of the carotid. So you should be knowing about the direct puncture as well as other accesses other than the femoral access. So these are the all hardwares you need to have in your lab when you are going to coil the aneurysm. So this is the case where ACOM aneurysm was coiled. This was the angiogram. This is the 3D. This is unsubtracted 3D. You can take subtracted 3D also. This is the final shoot where you are seeing two vessels. They are maximally separated. We could not separate it more than this. The catheter, the guiding catheter, you are seeing the coil, and the moment coil was going in, it will go forward. So you need to pull it back. Keep coiling it. As Dr. Batuk said, there was two markers on the microcatheters, and these two markers, the distal marker goes inside the sac, the proximal marker stays somewhere here, which is 3 centimeter distance between the two markers, and the keep coiling, keep seeing. Here, this is a coil which is going in, you can see here, and there was a daughter sac. There's no need to separately cannulate the daughter sac, because ultimately it will go inside the daughter sac the moment the major aspect of this is filled up, and finally you detach it with a electrical detachment. This is mechanical. So you have different types of detachment system. It may be electrical, it may be mechanical, it may be hydraulic. So even if your detachment, suppose your detachment system is not working at that time, then you can always break the coil. There is a wire inside, and you can pull the wire and you can detach the coil. So there are different ways of doing when you are stuck somewhere. So this is the final picture of this case. This is a post-operative scan. So it's not that endovascular is a one-time procedure. Open surgery, you open up the cistern, you open up the ventricles, your brain is lax. Whereas in endovascular procedures, we are giving more infusions, nimodipine all the time. So in your infusions, you are giving heparin, again infusions are going, you are giving nimodipine, here again you are increasing the flow in the brain. So you are actually increasing the perfusion, not decreasing the perfusion. And that is how you are increasing the volume in the brain. So you should be careful about the hyperperfusion which you are causing, increasing the load, increasing the edema, and hydrocephalus is not taken care. So you should be aware about this thing, and this patient may require the post-operative shunt insertion or some diversion procedure. So coiling is not one-time procedure. It has to be followed for many reasons. Apart from the regrowth of the aneurysm. So if you see this, after every procedure, you get this report, dose report, look at this. Look at this and you'll be horrified by seeing that the air karma, this is the kinetic energy which is released in the air, which was exceeding almost double the dose which you are doing by doing the complex procedures. So only one person should not be working in the lab. You should have a team people who keep exchanging in the labs, and you'll find that the outcome is also good. And whatever said and done, you feel tired when you do the any procedure where you're using the X-ray, whether it is spine or it is endovascular. Maybe endovascular less because you don't need to do the work of the arms also. So you have to be very careful, and it's important for the staff and the paramedical staff who are there in the lab. So this is another case where ACOM, I'm not very pro doing the ACOM coiling, but still sometimes you need to do. This was the patient who was on anticoagulants and with a very low ejection fraction, so not stopping anticoagulant, bled also. This was the CT angio, and this was the DSA, which was showing ACOM filling on from the right side. And this is the hardware which took 8 French check flow. Where small check flow, you don't need to remove it. You can keep it there, and you can leave it also. So small check flow, 8 French, Infinity, Vector DAC, and Accelerate of all of Striker. And you are seeing two points. One is this marker here and one marker here. So distal marker and proximal marker. And you can see how bad the spasm vessels. So these are the cases where it is difficult to take the 2 microcatheters, balloon or whatever. And there's balloon mounted microcatheters also, but they are stiff, gives you less flexibility to work. So this is a 3D CT angio. Better to do unsubtracted image. We are also learning with our lab actually. So different softwares also. So this is the coil being deployed. First coil, you are seeing that there is very little flow in the distal part of the ACA. So these things has to be kept in mind. Your terofibend should be there in the lab. And this was the software where you can see that how the blood is flowing and how the coil is going. नहीं चल रहा. This is not running here. Of course, you can see that at the end of the procedure, this only we could achieve only this much part which was filled up, and this part was not filled up. So we could not take the 2 microcatheters, we could not take the balloon. There was fear of occluding this vessel if we had gone here. So sometimes you have to do suboptimal coiling, but you need to keep these patients in follow-up. कुछ नहीं चलेगा ना, ठीक है. So this was the final thing which I was telling, that this was the part which we had to which we actually you have to create the neck, you have to create the lumen the way you do while clipping. So this is the, कभी चल रहा है कभी नहीं चल रहा है. अच्छा लेजर रहेगा ना. So this is the proximal microcatheter. Your coil has to cross this. The coil marker should cross here. So this is another case of DACA. This was This was made by our residents, so always involve your residents also. They'll give you, make good presentation, they will learn, they will understand, and you have to create the next team. ठीक है, चलने दीजिए. वीडियो नहीं आएगा ना फिर इसमें. अच्छा. वो प्रेजेंटर व्यू में वीडियो नहीं चलता. ठीक है. So this was the patient with DACA aneurysm, and he planned this case, what coiling will give, what clipping will give, and then he made this all diagram compared with the anatomy, because we are surgeon, we know this anatomy as well. And this was the case where this was just DACA, and this is how he planned, what all hardware he'll take. So always chart down what all hardware is there. We are in the government institution, so we may not have all the gadgets with us. So you plan out the whole case, and then again the same hardware was taken because it was DACA aneurysm, so took DAC with a long sheath and axillary end. Microcatheters are very good of Medtronic, Echelon and all. They are very good catheters, very low profile catheters compared to other microcatheters. And this was the final picture. So this is where you are seeing the both pericallosal and callosomarginal filling up, and grade 2, very little dye is there. But definitely these patients has to be kept in follow-up. And this is the final picture. This is a coil mass. You should always take the plain X-ray, which you can compare for the coil compaction. So you don't need to do bigger imagings. Just take the final X-ray. So another case of young lady who had PCA large aneurysm, partly thrombosed, and this was the DSA. These are with the machine Zyme, not with the lab, which we have installed recently. And this is such a giant aneurysm, AP lateral. These are the basic views which we should take. Then depending upon the direction, and you can understand what view is the best, where you can see the vessels separated. These are the hardwares. You should know, you should chart down what all you require. And then here the microcatheter is placed here, proximal is here, distal, this is marker is here, inside the aneurysm. Big aneurysm you can keep in the middle, small aneurysm keep at the neck. And then coil, follow the coil, and with the coil you can take the catheter inside. Just 1 minute. And here we put the coil, but if you are seeing the distal flow is decreasing, and you may use NBCA with the coil because it was inferiorly directed aneurysm to decrease the load number of the coils. That will be economic as well as not causing mass effect. And since there was decreased flow, injected tirofiban, and this was after, this was before tirofiban. And this is a flow after tirofiban. So you should be ready with these kind of complications. PCOM aneurysm, again balloon-assisted coiling because it is wide neck aneurysm. This is PCOM, wide neck. Actually, these are the vessels which should be nicely looked when you are doing surgery. Otherwise, they should be preferred for the endovascular, where stent coiling is difficult, so place the stent. So, to conclude, planning is very essential. Hardware knowledge is very important. Medtronic, J&J, Microvention, Ball, Penumbra, Stryker, Cook, Merit, Abbott. There are many Indian companies which are into the market nowadays, many Chinese companies as well. Teamwork is very important. Follow-up of the patients. Teach more, you will learn more. Imagine the case both as open and the catheter-based surgery. And this is the team of my department, and we are thankful to Professor A.K. Singh. Actually, because of his vision, we are able to perform the endovascular procedures. Thank you very much.
That was really a nice presentation. Any comments, questions from the audience? Yes.
Ma'am, just one question. What do you think is the optimal packing percentage of the coils for the aneurysm?
Yeah, if you see that formula 4 by 3 pi d divided by d1, 2, 3 into, we never think in those terms. That is a theoretical thing, right? So, yeah, so actually you should start your ideal size of the coil should be 1 millimeter bigger than the size of the aneurysm. But of course, you should be careful for the smaller aneurysms. Then you should see the packing density by the contrast, which is left inside the aneurysm. If you are seeing no webs, which is filled with the contrast, that is the best thing. And you should be able to see in all the planes. That is all.
Thank you, ma'am.
How to differentiate between the infundibulum and the blister aneurysm?
Yeah. Infundibulum, actually they are with the vessel, at the origin of the vessel. Like you have PCOM, infundibular dilatation of the PCOM. Whereas blister aneurysms will be not in relation to the vessel, main big vessels. Infundibular will be usually what you find is in relation to the ICA or basilar tip, where you find the blister aneurysms.
Ma'am, there is some literature showing there are multiple infundibulum, one at the PCOM origin, other at the superior hypophyseal origin. And sometime yesterday I read one paper showing blister at the, not blister, infundibulum at the ACOM. How to differentiate that position? That is not the blister or
yeah, you are right. That is how I told that if it is in relation to the vessel, it will be infundibular dilatation of the origin of the vessel. Okay. Right? So you need to follow up these patients. They may not require surgery in the first go. You need to follow up these patients. Every patient is not for the surgery.
That means in blister aneurysm?
Blister, definitely. If they have bled, you have to check them.
Okay. In case of ACOM, if I find that is infundibulum or blister, we should regular follow up that case,
yeah,
or
so,
to directly put?
So sometimes if vasculitis is associated, if they have bled, SAH, and the sequelae of SAH is happening, so follow them up, do the repeat DSA or the other imaging. Definitely DSA is better modality where you can pick up the infundibular better rather than MRI or CT angio. Follow them up and then see how they behave. And of course, these patients would be having hypertension, so control that also.
So, ma'am, how will you decide a filling coil of for this filling, framing and finishing coil? How will you take the coils?
Yes, it's a good question actually. Over years, what I understood that first coil definitely should be framing coil. In our hospital, initially we used to do the free coiling also before the PMG and all. So sometimes we had some limitations of the stock also. So sometimes even we have done with the 2D coils also, the first coil, the big aneurysms, where the neck is small and when the inferiorly directed. So there is less chance of coil migration. That comes with experience. But definitely first coil should be the framing coil and next will be the filling coil. But nowadays you have good 3D coils which are as good as the filling coil. They are not so stiff. So you can use them also. And just like gamma knife, where when you plan the gamma knife, you have one big ball, then you have small balls, small, multiple balls. So that is another way of filling up the aneurysm sac. But idea is that at the end of the surgery, you should not be seeing the dye contrast between the cells of the
So larger the diameter coils, it will be 3D and these are the framing coils.
So if large is the diameter, you are approximating to the wall. So there should be no dye should be filling up between the coil and the wall. So first size coil should be larger than the sac size.
Sac means diameter?
Diameter, yeah, maximum diameter.
Maximum diameter at the mid level, yeah, fundus. Okay. Thank you.
Yeah, but
nice presentation, Dr. Anita. So now you are a neurosurgeon doing endovascular as well as the microsurgery. So if you can tell me like which aneurysm you directly go for a surgical procedure rather than the endovascular, or yes. you decide on the basis of patients and the family wish.
No, patients come to us, but it's a very difficult and good question to answer. Patients come to us that I want endovascular. That is, every patient is coming to you. And I would say the person who is saying only you can be saved by endovascular procedures means the person who is referring, they do not have any idea of vascular surgery. One thing. Second thing, I always tell them that endovascular is not minimally invasive procedure. Here you are opening only this much. There you are starting from femoral to the arch, to the carotid, to the, so it is actually, in my view, it is more invasive than actually opening up. So we have learned from the beginning the clipping as well as the coiling. We have seen the bad times of endovascular, we have seen the bad time of open also. I would say that every surgeon should know how to clip the anterior communicating artery aneurysm, because we have many diseases of anterior skull base fossa which are more prevalent than the posterior fossa. So you should be encouraging at least institutions where we have teaching facilities, then encourage them to do the anterior communicating and middle cerebral artery aneurysm at least by open surgery. These are the two aneurysms. Again, when I was not very good in doing the ACP drilling and all, I used to think that ICA superior hypophyseal artery and all, they are good for the coiling, but we have opened up them where when there was no FD, we have opened up them and we have removed the coils also. So inferiorly directed aneurysms are better for endovascular, whereas superiorly directed aneurysms should be done with the open surgery because recurrence rate is very high. We have seen complications with the FD also, hemorrhagic complications, we all have seen. So we cannot say that FD is the answer for everything. So we need to be very judicious, and I would say that every institution should, and every surgeon should plan the same case both as endovascular and open surgery. Stryker and all, they have kept their labs, they have kept proper labs, proper means proper cath labs, where you can take the case, you can plan the case, you can do the case, you can run the case and come back with the hardware, what is going to be the end result. Maybe we can have, this may be the future that we can plan our case both open as well as endovascular and decide what is best.
Any time you have observed, like after explaining about the long-term results and the risk
they
of
have changed.
Yeah.
They have changed, totally changed.
Madam, one patient can undergo only one procedure. So what we are talking about is a very large group of patients. But for one patient, you will advise one patient. Either it is you advising or the patient's choosing. So how do you, the question is, how does one patient, either you decide or the patient decides? So what is this thing?
Yeah, ultimately, even patient has to understand what we are doing. We cannot tell them that this is what endovascular we are doing. We are giving 100% surety at this moment. When a patient goes for gamma knife, it takes 1 year for the result to come. May take more time also. So we have to be honest. We have to tell them this is going to be the outcome. So they understand, I think, many times.
I think we'll follow up later. Thank you, Dr. Anita, for your presentation. And I think we'll invite the next speaker.
Our next speaker, Dr. Batuk Devra, Professor, Department of Neurosurgery, LTM Medical College and Sain Hospital and Jaslok Hospital, Mumbai. And his topic is carotid stenting step by step. Already he talked about the hardware for the DSA. Now it's on the topic carotid stenting step by step.
So thank you, chairpersons. I'll be sharing my experience about the carotid stenting and how we do the procedure step by step. In fact, before the middle cerebral, or you can say middle meningeal artery embolization came into the endovascular procedures, like the carotid was I think the first procedure for the beginners to start with endovascular procedure. So again, like we have discussed in the previous, because now we are a hybrid sort of a neurosurgeon, vascular neurosurgeons who are doing both surgery as well as the intervention. So it is extremely difficult to decide in a given patient for a neurosurgeon who is doing both. For the interventionist, it is not difficult because they have only one option and they will give it. Why we have discussed in the past the presentation is because it entirely depends on the surgeon's expertise and the experience in a given case. So we all know about the carotid stenosis is the narrowing or the blockage of the carotid arteries because of the plaque. And that leads to the increase the risk of the cerebrovascular stroke that is associated with a significant morbidity and mortality. We all know it's a leading cause of a stroke. Carotid stenosis is a leading cause of a stroke in almost 30% of the patients. We all aware about the mild, moderate and the severity of the stenosis depending on the percentage, and that is counted on the basis of the NASCAT method. And we have two different group of patients. We have to always differentiate between these two group of patients. One is a symptomatic patient and another is the asymptomatic patients. As I have mentioned about the percentage of the stenosis is based on the NASCAT method. And there were a study that was conducted that has shown that if the percentage of stenosis increases, the risk of stroke is also increases. And for the same reason, several randomized controlled trials were performed comparing the medical therapy with the carotid endarterectomy for both the symptomatic and asymptomatic patients. And we know the results. There was a significant reduction of the stroke rate following the carotid surgery, or you can say carotid revascularization, in compared to the medical therapy. So CE was superior to the medical therapy for the prevention of stroke. However, in 90s, carotid artery stenting procedure was pioneered. And because it's a less invasive revascularization technique with the stent involved and become more successful in patients, pivotal trials were performed to obtain FDA approval for the head-to-head comparison between the carotid endarterectomy or CEA and carotid artery stenting. And we all know about variety of trials being published, and they published the results. Overall, cumulative evidence demonstrated that similar outcome between both the treatment forms, like either intervention or the surgery. However, there is various guidelines published by various societies, and these guidelines vary in their recommendation both in the symptomatic and asymptomatic patients. So there was one guideline published in 2017, and they have clearly mentioned that about in a symptomatic carotid disease, there is a class 1A evidence about the carotid endarterectomy in compared to the class 2B evidence in a patient for a carotid stenosis treatment. So in my practice, I mainly do the carotid and stenting procedures for the high-risk patients, and the rest all will plan for a carotid surgery. Again, the decision-making was difficult in a patient with the asymptomatic patients in those olden days, but now with the availability of the best medical management, that has significantly changed the treatment method in asymptomatic patients. And more patients were given antiplatelets medications with the lipid-lowering measurements along with the glucose control and the blood pressure management. And declining the stroke risk in these patients treated with the BMT, and therefore limited the applicability of prior landmark intervention trial in compared to the previous trial. So the landmark trial that came into publication recently, medical management and the revascularization from the asymptomatic carotid stenosis, we were all discussed about the symptomatic, but now the asymptomatic patients. So the conclusion is, in addition of stenting led to the lower risk of composite preoperative stroke or a death rate or ipsilateral stroke within 4 years than intensive medical management. There was the carotid endarterectomy did not lead to significant benefit. It means like asymptomatic patient with a carotid stenosis, there is a role of carotid stenting, but there is no role of carotid surgery. So after understanding these various trials and the various the procedures in detail, there are right now two indications for carotid stenting: symptomatic carotid stenosis and asymptomatic carotid stenosis. When we talk about the carotid stenosis, we also have to keep in mind about the carotid ulcerations, that is giving the symptoms to the patients. There are contraindications. There is absolute contraindication for the carotid stenting. You can see there is a significant carotid stenosis here. But if we see the DSA, this was the CT angio image, we see the DSA, there is a fluffy thrombus here. This is an absolute contraindication for immediate carotid stenting, and this one has to either give a low molecular weight heparin and the anticoagulant medications before planning for any intervention procedures. So one such case was having a recurrent symptoms, and we planned for a carotid surgery, and you can see the thrombus, the atheromatous plaque with the bleed. Again, many times significant stenosis, you have to very closely plan your patients before doing any carotid stenting procedure, because slightest thrombosis at the site of the stenosis and you plan for a stenting and your stent is bound to thrombose. So again, this patient underwent the surgery and the thrombus was found during the surgical procedure. So now when we plan for a carotid stenting procedure, again I'm showing this slide, like either you have a biplanar machine or the monoplanar DSA machine. And in the previous speaker, we also discussed about if you have a facility for a CM, good quality CM, you can do this procedure, at least carotid stenting procedure, you can do under CM with a good fluoroscopic imaging. Always we need to have a preoperative evaluation in the form of the preoperative neurological examinations. You should be clear in your mind before planning patient for a carotid stenting procedures, like history of iodinated contrast as such as like other intervention procedure. One has to be encounter all these things about the serum creatinine, coagulation parameters and all. Pre-op usually keep a patient's NBM for 6 hours and always one peripheral line with for the angiography we don't do Foley's catheterization. On all intervention procedure we put a Foley's catheter, and of course you need to have a consent in detail about the risk and the type of complication associated with this procedure. Any patients receiving a stent should have antiplatelet medications to prevent the thrombus or thromboembolism during the procedures, particularly in-stent thrombosis. So we usually, most of these patients, because of the stroke, they are on medications, either aspirin or a clopidogrel or a combination of both. Then there is no need to give additional dose, but previous morning, both the medicine patient should receive. Alternative, patient is not receiving a medication, we should load the patients with the 300 milligram of aspirin and 300 milligram clopidogrel before the procedures. Nowadays, we have a ticagrelor available that we can load the patients with the ticagrelor maybe 1 or 2 hours prior to this intervention procedure. Now the questions come under whether to do the procedure under local anesthesia or a general anesthesia. Usually this procedure is being performed under local anesthesia and very infrequently under sedations. And one has to, we always insist anesthetist presence during this procedure in the lab. The advantage of local anesthesia is having a continuous neurological monitor in compared to the general anesthesia. But the patient who is not cooperative, we cannot perform the procedure under local anesthesia. One has to have a complete checklist before you start the procedure: IV line, anesthetist presence, facility for intubation, indwelling catheters, warm-up, because many of the times we perform the procedure in a cath lab and patient is awake. So we have to be take care about this thing. Always keep IV atropine or glycopyrrolate ready and protamine in a lab. Drugs to increase the blood pressures like dopamine or norepinephrine. Angiography we have discussed. Usually we perform angiography with the 5 French sheath and then just confirm the diagnosis when there is carotid stenosis. So these are the prerequisites for the angiography procedure, like the femoral angiography sheath, wire. Many times we keep this 120 centimeter long 5 French angiography catheter to have a good telescopic navigation and place the guiding catheter into the proximal carotid artery. For the carotid stenting, will require a 8 French sheath, 8 French guiding catheter, carotid balloons of various size. If you are aware there is a significant stenosis, maybe around 95% stenosis, you will not able to navigate your protection device, you have to pre-dilate the thing. So you require a very small 1.5 millimeter balloon with it. So you have to assure everything before you take the patient for a intervention procedure. Always like a protection device and keep the various sizes of carotid stents available. So there are, as we have seen in the endovascular, the tools, like we have different companies are manufacturing things. So we have these are the Precise from the Codman, and then Protege stent from the Medtronic, then the Abbott. So main important thing is whether the stent is like a open stent design or a closed cell design. So in a tortuous, always like open stent design stent is better than compared to the closed cell design. We always, like as I mentioned, I always do the procedure under digital protection device, and again there are various digital protection devices available in the market. I usually put either AngioGuard or the Spider X. AngioGuard is from the Codman and this is from the Medtronic. Access, we have seen in the previous presentations, usually femoral artery. Suppose you have done an angiogram and in the same sitting you are planning and you already loaded patients with antiplatelets. We just take out the 5 French sheath and put the 8 French sheath. And either using and once you put a 8 French sheath through the angiography, we perform the angiography first. So these are the initial steps. Under the fluoroscopy guidance, always, because these patients are elderly patients, like many times there is a significant narrowing in the common iliac vessels. So if you are not careful, then you can create a problem, a dissection of the vessels. So under fluoroscopy guidance, you take your angiography catheter in the ascending aorta and take a shoot and understand the type of arch, whether it is a type 1, type 2 or type 3 arch. So you will not have a difficulty in navigating the guiding catheter. So these are the type of arches. The class 3 will have a more difficulty compared to class 1. So many times because of the class 2 or class 3 type, we need to use a SIM catheter. So here under fluoroscopy guidance, you have to remove the 4 French and you again go with the 4 French SIM catheter. And under fluoroscopy guidance, you have to give a shape. You have to understand about how to give a shape to the 4 French catheter, SIM catheter especially. So here, So here the bit sort of a cobra shape was given to have access to the common carotid artery on the right side. So this is the images like. So once you assure the type of arch, like there is a type 1 arch, then you go with the angiographic catheter and put you under fluoroscopy guidance, put your long double length wire. Normally we do the procedure with the angiography procedure with the 150 centimeter long wire, but with the exchange technique, because we have to exchange the angiographic catheter with the guide catheter. So you exchange the guide catheter and put the guide catheter into the common carotid artery and then take a shoot, confirm the stenosis, and then you have to see whether you will be able to pass your angioguard without any dilating the stenotic segment. So once you are sure you will be able to pass your wire through this thing, so over the roadmap guidance, you advance your micro wire, so that is 014 wire under fluoroscopy guidance. So many times it goes without any problem, but sometimes you need to give a shape. So once you your wire is in and cross the stenosis, you deploy your protection device. Here we use Spider X. So how to select the size of the spider protection device? So protection device should be the size of the actual distal carotid artery where you are going to put, and the balloon size should be lesser than the size of the artery, and your stand should be over the size of the artery. Like means suppose 5 millimeter vessel, distal internal carotid artery. So select the spider of 5 millimeter, balloon of 4 millimeter, and this stand of 6 millimeter. So once you park your this thing protection device, you can see here the protection device distally. This is. Then you advance the balloon, pre-decided size of balloon. So here you do the balloon angioplasty. Your anesthetist has to be careful, because this time if he is not around and patient can develop a bradycardia and the hypotension. So always be careful during this step. So after the first angioplasty, there was no significant opening. So we did a second balloon angioplasty, and this is the second balloon angioplasty. After second balloon angioplasty, there was a significant opening of the stenosis, and then we have advanced 4 centimeter long, 6 by 8, 6 millimeter distal diameter and 8 millimeter proximal diameter stand across the stenotic segment, you can see. And then it was deployed. So the stand is deployed. You can now see the deployed stand along with the protection device. So always after deployment, you take a run and see whether there is any changing happening at the site of the stenosis. And always confirm there is nothing happening inside the intracranial circulations. So once you ensure, we always wait for maybe around 10 to 15 minutes before removing the spiders. So, or a distal protection device. So here the spider was used. So this is how we remove the spider. So over the wire, you advance the spider retriever, and then you take that spider inside this catheter and remove this thing. So at the end, always confirm there is a patency at the stenotic segment. And before shift the patient, you always make ensure there is nothing happening in at the puncture site. So whether to use a protection device or not, the literature is varies, but it some of the publication it says like if you don't use, there is a 4-fold increase in the size of in the incidence of stroke in these patients. Post-operatively, patients require observation in the ICU, requires detailed monitoring and the neurological examination. We usually remove the sheath after 6 to 8 months after PTI are normal, and start oral feeds and the catheter next 1 or 2 days. Usually, we keep a patient for a follow-up after 1 month, 3 months, and then 6 months yearly follow-up, and continue with the antiplatelet medications. Before that, we always do the CT scan to rule out the clot. So second day morning, we do the CT scan, and then we start the antiplatelet medication. This is our share of management of the carotid stenosis, either both the procedures like surgery and stenting. And in our series of 65 patients, there was no significant difference between either of these procedures. So these are some of the cases, like 55-year male patient presented with 2 episodes of TIA, right-sided significant stenosis, and that was a high carotid bifurcations. So these patients, we did a stent. Again, like the significant stenosis, 2 episodes of TIA, previously patient had, and patient was having a left ventricular failure. So this patient, again, we did a carotid stenting. Here you can see the ulceration along with the stenosis. So this patient underwent carotid stenting, you can see. Many times when we see the follow-up, we see there is a complete occlusion of the artery, but this is artifact, so one has to be very careful about evaluating these patients. Many times high bifurcation stenosis, surgery is not possible, and in spite of medical management, patient was developing the symptoms, so we decided we'll put a stent. So using a protection device, we deployed a stent in this patient. So a carotid angioplasty is a minimal invasive endovascular procedure to treat the carotid stenosis, especially in the high-risk patients. And I think all the interventionists who start their intervention procedure should start with this basic intervention procedure. Understanding the techniques and the various tools are paramount importance for a successful outcome in this patient. Thank you.
Thank you, Vatuk. I have one question. In which conditions you would not like to prefer the protection device?
As far as possible, I will like to put a protection device in all the patients.
Right.
Suppose like the last case I show, there was a significant stenosis, very high, maybe extending into the petrous component. In those patients, sometimes it's extremely difficult to put a protection device. Many times we see a very tortuous distal internal carotid artery. That time also we have to be careful. I am not telling will not put, but we have to be very careful about putting a protection device.
So, but in those patients where you have a tortuosity and you are not able to put, or rather you would not prefer to put, then the chances of the complications are high in those particular cases. What do you do in that?
See, basically literature is mentioning that if many times you don't do the distal protection device, outcomes are not different in both the patients, both the group of patients, in some of the literature. But see, tomorrow suppose some patients develop a problem and medico-legally, why you have not used? So it's very difficult to justify. So practically in all the patients we try to, as you have mentioned, in some patients like very tortuous, it's not possible, then we don't have any options. Another thing, like in a similar condition, like we discussed with the Paritosh, in acute occlusion of the internal carotid artery because of the stenosis, where you are aspirating the clot, there is a stenosis, and you cannot do, you cannot put a distal protection device many times.
In those patients where you got very significant stenosis and you have deployed the stent, so what is the long-term outcome in those particular patients?
those patients who are having a 95% stenosis, one has to be very careful about. Actually, I had a case, but because of the time, I was not able to. You have to be very careful. Two patients, like one patient is significant stenosis, more than 95%, and second thing, previous stroke, because these patients are prone to develop a hyperperfusion injury following the opening of the stenotic vessels for a longer time in the previously damaged cerebral parenchyma. So I had a case of a similar, of a significant, almost 95% stenosis. We opened immediately after a deflation of the balloon, patient developed a seizure, and we need to intubate. Initially we did a plastic, but plastic was hardly, maybe 20-30% we were able to open the artery, and finally we have to abandon the procedure. Patient developed a hyperperfusion syndrome, and though he completely improved over a period of 7 to 8 days, but you can have a problem with the significant stenosis first, and second thing, a previously insulted brain.
And how frequent is it that you are trying to do this stenting and you end up doing a CA?
So I had two patients in which I was able to inflate the balloon, but unfortunately even 5mm balloon I was not able to inflate the, open the stenosis, and I terminated the procedure and planned for a carotid surgery in both the patients. Because though both the patients were according to my study, both not a high risk, but the patient's family were demanding. They don't want to undergo any surgical procedure. So we plan for stenting.
Right.
Sir, how frequent the restenosis of the stenting?
Restenosis rate may be around 2 to 4% in the literature, but many times we do not have a regular follow-up of these patients. If patient do not have any problem, they will not come for the follow-up.
Okay. Then treatment, sir, same? Angioplasty or some?
Yes, the treatment is same. Restenosis, I think surgery will be extremely difficult.
Okay. Have you seen any fractured stents or what book complication has given?
I have heard about, but I have not, in my experience, I have not seen the fractured stent.
Oh. And is there any age contraindication for stentings?
At any age you can do, provided like it's a clear indication for the surgical, for the carotid stenting.
Some book I read that after 70 relative contraindication at
that depends on the patient family members. 55-year male, significant stenosis, family say we don't want to do anything. I operated a patient of 96 years, atlantoaxial dislocation. Patient asked me, doctor, are you confident to operate me at this age? He demanded, in fact. So that entirely depends on the patient and the family.
Patient attendants are ready. Is there any anatomical relative contraindication so that difficult to navigate the system? Because as the age progresses, the tortuosity of vessel will be increasing.
So we take all this decision after discussing with the family. If you have explained to the family member, there are 50% chance patient will have a problem during the procedure. They may not take a decision for a procedure.
Okay, sir. Thank you, sir. And one more question. Is there any, if bradycardia happens, have you used the pacemaker for the, instead of atropine and pacemakers? I have seen that, that's what I was asking.
So I am just sharing my experience. When initial days I was sharing the cath lab with the cardiologist. So during my first case in the cath lab, actually because the lab belongs to the cardiologist, so he came first, he secured arterial line, he secured a venous line, everything was ready. When I asked, like, why is venous line? He said, if suppose something can happen, I will do the pacemaker. I will use a pacemaker. So but as a neurosurgeon, I have never used a pacemaker in my case. We always give atropine.
Okay, so regularly not used. So when your cardiologists are available, you can use.
Yeah.
Pacemaker I'm asking. Temporary pacemaker.
So that's what I'm telling. Okay, I have not used, but if you have a problem and the cardiologist is around, you can use that facility. Yeah.
Thank you, sir. Thanks for clearing.
Very nice lecture, Dr. Batu. One thing is, what about pseudo dissection in carotid?
Pardon?
Pseudo dissection, carotid, and stenting.
Dissection is very common if you are not careful with your balloon angioplasty, and immediately you have to put a stent. That's the treatment. Because if you try to, because many times you have to study this carotid with a CT level, significant calcification, if you try to open that stenosis with a 4 or 5 millimeter size balloon. that patient can have a dissection, and immediately you have to put a stent, that's all.
And what about the experience about post-radiation carotid stenting? Like right now the cases are also increasing, head and neck, and then post-radiation there are so many patients coming with the stroke, and then what are the tips for that?
You have to be very careful about the stroke, this stenting in these patients. In fact, in one patient, we have operated and put a patch because that patient was referred from the radiological unit because they cannot put a stent in this case. Many times you see in the atherosclerosis, we always see the single, very short segment stenosis. Many times the post-radiation, you see the very long segment stenosis. So you have to be very carefully making a decision in these patients.
Thank you.
Antiplatelet regime, you are using still clopidogrel, not switching to the, because 20-30% resistance is there.
Yeah. So I mentioned about those patients who are on antiplatelets medication, aspirin, clopidogrel. We give aspirin and clopidogrel because many times it's affordability is also an issue. But many cases we have started using clopidogrel, this thing, Brilinta, that is ticagrelor.
Ticagrelor. Okay.
But it is not a routine we are using.
Okay, and forgot to ask you, you are also a hybrid surgeon. What will you do, which cases you will do coiling, which cases you will do open?
So I will say in a case of ACOM aneurysm, middle cerebral artery aneurysm, I will always insist we will do the surgery. Again I am telling you, it's a patient's, even pica aneurysm, I will insist for a surgical procedure. You will not believe, once you explain to the patient's family members about this surgical, no doubt it depends on all your expertise as well. But once you convince them in my hand, because this patient maybe 3, 4, 5, 6 years down the line they will come and they have to earn the same amount of budget for the same sort of a procedure in a long term. So if you explain to the family, they usually agree, but many times it happens. Even two patients, in fact, while waiting for money in my hospital, in my department, we lost them because they were so counsel about the endovascular procedure, they were not ready for a surgery. And that day onwards, we have decided if you are not willing for a microsurgery because you don't have money for endovascular, we will not keep in the hospital. Either we will discharge or you take whatever it is. Because we cannot, as a neurosurgeon, we can clip anytime. But we cannot see patient dying in front of us.
Thank you very much.
One question, sir. One young patient with MCA territory infarct, and on DSA we found there is a carotid dissection. And what should be the plan? Go for the standing or medical management?
Carotid dissection?
Carotid dissections.
Many times, usually these patients come from the neurologist, so many times they are on anticoagulant medications like. Many small carotid dissections subsides by its own without...
That patient having enlarged styloid process.
Pardon?
Styloid process that was enlarged.
Okay. So maybe then we have to put a stent across the dissecting segment.
Dissecting segment. Can we put a cover stent in that place because that dissection is much higher than the bifurcation?
So yeah, you can put a covered stent, but the problem with the available covered stent. So you said it was not crossing the petrous?
Not crossing the petrous.
So even though if it is not crossing the petrous, we can put a C-guard. If the anatomy is straightforward, you can put a C-guard covered stent. One of the cases I have shown in the dissecting aneurysm in the previous presentation. There was a post-traumatic aneurysm in the ICA, just above the ICA origin. So in that location, we can put a covered stent.
Sir, there is any other place where we can put the cover stent in brain?
Except brain, we cannot. Brain, anywhere where there are vessels, we cannot put a covered stent. Because once you put the covered stent, you will sacrifice the perforators, all the perforators immediately.
Okay.
So covered stent only maybe into petrous carotid. Very rarely in the beneath the petrous carotid, very rarely in the petrous carotid.
In CCF, there are many people are putting the covered stent. No?
Please keep the short question because we are running late.
CCF, we cannot put a covered stent.
Thank you, sir. Thank you. And we keep on the discussion on the leisure time. So our next speaker.
I think Dr. Vikas himself. Dr. Vikas, now he'll be talking on AVM embolization, again, step by step.
I hope everybody is enjoying the discussion and learning the techniques, and it appears to be very interactive. After so many of interactive sessions now coming to the AVM, and lots of things have been already been discussed and told by our experts about the technical aspects of the DSA, how to access the vessels and how to reach, do the carotid stenting, do the coiling. Now coming to the next topic, that is AVM. Lots of people say surgery is the better, radiosurgery is the better, best. And we are doing microsurgery also, we are doing the AVM embolization also. And what I had noticed, it is one of the things that that requires a lot of anatomical knowledge, anatomical considerations, before lot of planning, before venturing into its embolization. But I think once you are doing regularly these lessons, then you are going to get acquainted with the anatomy also, then you are going to understand the dynamics of the AVM also, and you are comfortable with using the different embolizing agent as glue, onyx, squid, and fill type of liquid embolic agents. So I was doing it since I had joined in SGPGI as a resident, and the first topic that was allotted to me by Dr. Sanjay Bihari was concurrent transmit arteriovenous malformation. That was a macrosurgical topic, but running between the radiology department and the neurosurgery department has just given me the insight that there is something that needs a lot of considerations. And further, when I had gone to Zurich, I had a lot of things from Professor Valavanis and SRL itself that had given me a little idea of how to deal with these complex lesions. So coming to the AVM, AVM has draining artery, draining vein, and the nidus. Nidus is a congruent dysplastic vessels in between the draining artery and draining vein. Now, just to give you a little idea about what the AVM, the technical considerations that we, beyond this feeding artery, beyond this nidus and beyond these veins, are the location, which is of paramount importance. Either it is located in the sulcal region, either it is located in the gyral region, or it is the conglomeration of both the sulcal region and gyral region. Because, the position in the sulcal region and the gyral region decides the feeding artery venous patterns and even the angio architecture of the AVMs. So majority of them are sulcal, followed by gyral, and followed by the mixed. It is just to give you the glimpse before I come to the step-by-step AVM embolization process. Coming to the classification of the system of feeding artery, it is not always that we encounter that the arteries that are feeding to the AVM is end artery. It is maybe in passage artery that are passing through the AVM and just supplying some feeders on the way. So if we don't localize them as in passage artery or feeder artery, that while doing the embolization, there are fair chances that we inadvertently damage, we eventually block, we may produce infarct and other things emboli in the main feeding artery as compared to your in passage artery. So it is, while dealing with this feed, after DSA, we should decide either it is a monoterminal, it is a multi-terminal or zero-terminal, and either it is a transient artery or it is retrograde arteries that are supplying to the AVM. The types of the nidus, either it is a plexiform or it is a fistulous communication that we come across while we do the DSA by counting the frame. So it is important for us to know either it is a plexiform or it is a fistulous, because technical considerations varies in those cases also. Coming to the compartmental composition of the nidus, because it can be single compartment, it can be multi-compartment, it can drain through the single vein, it can be fed through single artery, it can be fed through the multiple arteries. Similarly, there can be the single draining channel, there can be multiple channels. So it can be monopedicular, multipedicular type of things. Coming to the internal vascular cavities, there can be arterial aneurysm, pseudo-aneurysm. Many times we get the arterial loop and we confuse it as aneurysm. And perhaps venous internodal cavities are also there, dilated channels. We have a lot of cases doing these things, and we come across such complexity more oftenly now. So coming to the case summary, after just have a look at these anatomies so that it will give you idea of doing the things while performing the AVM embolization. I am going to give you a step-by-step demonstration of the AVM embolization of a 45-year-old female who has come with the vertigo, vomiting, and she was it was a very disseminated, but she was having ultrasensorium also at that time when she reported in our department. There was flow whites in the region of the right parietal lesion. After doing the DSA, we had localized the AVM in the posterior circulation fed by the vertebral artery. So we have the access of this artery through the vertebral artery. The guiding catheter was put into the proximal vertebral artery, that was the cerevase. And after putting that cerevase, the next was we had taken Nevian toward the distal C1 segment. You can see the angio architecture of the AVM that was having multiple feeders from the PCA. You can see it here. At least I could identify 3 to 4 feeders while doing the initial DSA. After that, after localizing these feeders, you can see here, it was supplied from both the PCRT and it was also supplied from the MCA. It was a watershed arteriovenous malformation. There was more of sulcal than the gyral pattern. So we had localized it. After localizing, we had gone through one of the, you can see, it is a marathon having Chikai wire. That was marathon is a 017 marathon flow guided catheter, and it is and the marathon and it Chikai wire is 018 wire. That is it is a fast sequence that I'm seeing you. It requires a lot of patience because the artery was tortuous and we had to take a lot of effort at the beginning only to cannulate the artery with the marathon and go ahead with the Chikai wire. So next step was embolization of one of the artery. So we have taken the selective, super selective DSA, and it was one of the compartment that we had localized through middle feeder. And after localization, we had put the, you can see here, we had put the marathon at this place and started injecting the glue. That was after having dilution of 33%, 1 ml NBCA with 1.5 ml Lapiodol. Once it started having backflow, we had stopped there. Now coming to the second feeder, this is after first articulation and embolization. Then we had gone for the MCA feeder because the localization of the second feeder from the same site was difficult. So we had gone through the MCA feeder, and in the MCA feeder again we had used the marathon microcatheter and the Chikai wire, and the principle is that we should go as distally as possible inside the AVM so that the reflux should not happen in the main wire, not the main feeder wire that I had told you earlier. So you see here, the marathon is coming into the AVM nidus. We had pushed it as distally as possible and we had taken the super selective angiography image here. And you can see the compartment here, and it is draining into the faint drainage into the vein. So coming to the next, the glue embolization of this compartment. So we had slowly started, after putting these things, you can see the super selective images of that compartment. And we had started putting the glue. You can see the flow of the glue filling the AVM. And you have to take out all the compartments one by one. You have to take out all the feeders one by one. It is a, I will say, if stenting aneurysm is a 100 meter, 200 meter race, you can see here, embolization of the AVM is a marathon process. It requires a lot of patience. Once you see the backflow proximally, you have to stop just near the AVM so that it should not come to the main feeder artery. After the MCA feeder embolization, you can see the part of the AVM that was still remaining, and there was draining, there was slowing down of the drainage in the vein, but it was still there. So we had come to the next day for the second sitting of the embolization. Again, we had gone through the PCA artery. You can see, we have taken the road map. We had gone again through that. And in the second stage, we had got the delineation of the feeder artery better than as compared to the earlier, because you are tired also, things starts getting blurred and you lose patience also. So next day, still we were facing the same problem of cannulating, putting the macro marathon there, moving it to as distally as possible. You can see here, these are the faster images that I am showing you, but it takes a lot of time to negotiate. And you know, you can see the movement of the wire, how it cannulates and how it goes distally. So it has gone, and we have taken it as distally as possible. You can see it here. So it has again gone into that compartment. So after putting there, we had taken a super selective shot of that compartment. Already these glue casts are there that you can see here, that was done in the earlier stage. It is stage 2. And after taking the super selective road map, we had started putting the glue. You can see it here. It started reflexing, and we had to stop it here as usual. But it had taken care of that compartment. Now this is the almost complete glue cast, and this is the check DSA. After doing all the embolization process, the AVM was gone. There was little, that was hampering in the PCA distal circulation, but I will show you, this was fortunately taken care of by MCA territory, MCA branch. So AVM was gone. The vascular supply of the territory was good, collaterals were there. You can see here the glue cast was there, and there was complete obliteration of the AVM. Patient was having serious headache, severe headache, and it was a throbbing in nature. And after doing all these procedures, patient was relieved of headache and vertigo, and patient was not having any neurological deficit. This was the final post-op CT. You can see here the glue cast. Now coming to the second case, it is a case of complex AVM. It was having multiple feeders from the posterior circulation vertebral artery, PCA artery. And we had again gone through the vertebral artery territory. You can see it here. We had taken the road map, and we are again trying to go through the vertebral artery. We put a guiding catheter here in the proximal segment. We go distally by placing the Navian in the proximal basilar segment. And this is, you can see it here. This is a Navian that we had put it as a distal access catheter, and this is the movement of the marathon. And with marathon and Chikai wire, we had gone distally. You can see here, there is at least 3 feeders, one on the superior aspect, one in the middle aspect, one in the lower aspect. And once you go inside the AVM and take the super selective shot, then you come to know what are the drainage pattern of the compartment, how many feeder arteries are there, how many draining veins are there. And above all, even after taking the super selective angio of the compartment, you are not sure that these compartments are either communicating with each other or not. So super selective just give you an idea. But many times when I am putting the glue, then the communication of the different compartments comes into picture, and then I start putting glue further. Otherwise, I have to stop, because distal embolization of the glue can cause a catastrophe. So you can see here, first I had gone into the one of the middle feeder. This is a marathon, this is Chikai wire. Slowly we had gone there. We had put the marathon as distally as possible in the AVM, and it was put in the distal segment. You can see it here. It is going here, and it has reached here. After reaching at this place, we thought that it is being fed by both we will take care of both the superior segment and middle segment only. But after this, we had taken the super selective angio to delineate the compartment. You can see it here, it is here. And after cannulation of the super selective cannulation through the middle PCA feeder, we had taken the road map. We had started doing the glue embolization. You can see it here, the movement of the glue. Sometimes it is difficult to notice where it is going, but it is not going the main feeder channels or venous channel. So One of the compartments of AVM was taken care through the middle segmental embolization. Coming to the next feeder, again, we had taken the DSA, we had, you see here, a lot of AVM is still there. We had again taken the DSA, we had again gone through, you know, earlier we had gone through the mid segment, now we are going through the superior segment. And at this place, you can see, this is the moment of the marathon. It is, and you can, wire had already gone into the distal segment and marathon is following it, and we had put it in that superior compartment. Already the glue cast of the previous embolization, you can see it here, there are little glue that has gone into the draining vein that is required, because you know, you have to get slow down the venous drainage also as you are feeding it, but you have not to completely obliterate it because it will cause hemorrhage and it will be a big catastrophe for the patient. So after putting the marathon and cannulation of the second feeder, we have to take, you know, the super selective angio again. You have just put it there. Now this is the super selective angio. You can see here the filling. There is faint drainage of the vein also. So after that, we had taken the roadmap at this stage only and started the glue embolization. Generally, I prefer to use 33% concentration of the glue, 1 ml NBCA and 2 ml Lapiodol. You can see here the slow filling of the compartment through the superior cannulation, and you have to make sure that you are in control of while you are doing the glue embolization, and you have to see here in the periphery also that where it is going, because you know liquid embolization is always going to fly here and there. So after second stage of second feeder cannulation, you can see here there are small chunks of AVM still persisting. So we had gone for the embolization of the third feeder. So it is a step-by-step process. Embolize one feeder, then the second feeder, then the third feeder. So you can see here the glue cast, and we had, after it appears to be very complete, but while taking the DSA, it was a large chunk of AVM that was there. We had again gone through another feeder. We had taken the marathon here, and we had put it as distally as possible. And the purpose was, because you can see here the proximity of this feeder from the PCA territory, PCA main branch. So you can see it, the movement of the marathon that has gone distally. And after that, putting the marathon distally, we had taken the super selective angio, which revealed this compartment filling. You can see it here, the glue cast here, in the last compartment here. Again, we had taken the roadmap. After that, we had started filling through the glue, and slowly it is filling. You can see the slow filling of that compartment with the glue and making a cast. So you have to be very slow, and that you learn by putting regularly these things, how to do and where to stop. So this was the third stage embolization of the same AVM. So after taking out much of the feeders were embolized, and after we were thinking that there are much AVM that was left. So you can see here the glue cast, the glue in the venous tail, and finally we had got this picture. Majority of the AVM compartment was taken care of, although I think this was perinidal angiogenesis that was more visible, but there can be some small residual AVM still. So you can see here the glue cast that was present in the nidus in the AVM. So finally, at least 90 to 95% AVM was taken care of. We are planning for the next sitting. So you have to make it a stage embolization when such type of complex AVM is there. So this, you have not to get worried after one attempt only. So this is a slow process. I would say this is not a hit and run, but it is a marathon that you have to take the patients. You have run through the lesions, we have to, because dynamics keep on changing. So this was the demonstration of the second AVM. Just to mention the third case, why I want to say, because this, you see here the flow wide here, the venous drainage here in the MRI. After the DSA, you can see it here. It is being fed from the pericallosal artery. There was draining, directly draining venous into the sagittal sinus. And after going through it, again, superselective embolization was taken, and it was embolized through the glue. And whole AVM was embolized by using the same thing, marathon and Chikai wire and glue, 33% dilution. And after the embolization, the AVM was completely obliterated, and you can see the glue cast. This is the nidus, and this is the cast in the veins. Just to mention next case, that was a small, the defect in the, sorry, time is over. So it was a very distal AVM. You can see it here. It is very difficult to localize that, posterior collicular region. It was very difficult. We had taken the super selective catheterization. You can see how distally it is located in the posterior collicular region. And we had, and there was dilatation also. Finally, we had reached there, we had embolized there. So it requires a lot of patience, a lot of planning, understanding the feeder artery, understanding the feeder veins, and above all, the patience of the surgeons. So with this, I finish it, and if any query, you can ask me. Thank you. So I think...
Sir, many people talk about combined arterial and venous approach for AVMs. What is your say on that?
Actually, while we are doing, its purpose is to complete obliteration of the AVM with, taking care of the venous drainage also, because you have to reach to the tail of the vein. Because if you don't reach there, then it is not going to cause that much the benefit of the patient. So, majority of the time, while you are selecting the feeder artery, these things are taken care of. Sometimes what happens, these feeder arteries are not that much having caliber that you can selectively catheterize that, and at that time, venous cannulation and reaching up to that appears to be better as compared to feeder artery. But conventionally, what is, I would like to say you that we are more confident and we are more adapted to doing the feeder artery embolization, both as a surgeon and because of our expertise and doing the things conventionally also. But now, a lot of people are saying that venous things are there. I have done few cases and the results are also good. But in venous, I think for beginning, it is always better to go through the arterial feeders, and when you are developed sufficient expertise, it is better to go through the venous. And ultimately, it is the decision about the combined arterial and venous type of things. So.
Okay, thank you, sir. And glue versus onyx, how do you decide?
Actually, what happens, that is, no, you have the expertise, you have the convenience, there are economic circumstances also, because glue is very cheap. In 20,000, you can take out the whole of the AVM, you can go for the first stage procedure, you can go through the second stage procedure. But onyx requires, is a costly also, and I think it all depends. Because onyx is having a fundamental physiological feature that it behaves better than the glue. So you are more comfortable with onyx as compared to glue. But I think if you are using the glue regularly, then you can also have the same result as compared to onyx. And it is a resourceful also, because it is cheaper as compared to the onyx. So that way it is that we prefer in the setup. But where the luxury of using the onyx is there, you can use onyx, you can use speed, you can use fill also. So
okay, thank you, sir.
Okay.
Thank you, Dr. Vikas. So doing so much complex things for the AVM. And now our session's last speaker, Dr. Anita Jagatia ma'am, Professor and HOD Neurosurgery, GV Pant Hospital. And very important topic for avoiding radiation hazards in the endovascular procedure.
Yes, sir, thank you. It's indeed a very important topic, not for surgeons or the person who is operating, for whole staff who is around. That includes paramedical, nursing, technician, even sweepers also. I wish many people must have been here for this. In fact, thanks to Vikas that I went through this radiation safety, and even I got to know a lot. In fact, my seniors, my teachers used to say, "Arey, dur rakho haath," when you are putting the screw. Leave the instrument there and go, keep your hand behind so your fingers are not exposed. So you get the less of the radiations. So it is very important topic to understand. Thanks, Vikas, for giving me opportunity. So, if we say, what is the need to know about this? We have the physical risk to operators and staff, and at the same time, we have legal implications. Normally, we never think about this part, but they are now existing. So if we see this class 1 recommendations that an informed consent should be taken that a person is exposed to the radiation, which I think we never do this. And studies say that if we do our micronuclei assessment of the lymphocytes, we get the radiation changes. And these are the two tests, protein G, H2AX and PATM. And you may find that they are found in the circulating lymphocytes, and they are the biomarkers for the radiation exposure. So there are few terminologies which we always see on our C-arm. At the end of the procedure, we should always see, and during the procedure also, we should have a look that what are we getting. Like gray is the mean organ dose, and it is absorbed dose, which is actually joule per kg of the radiation. Sievert is again effective and equivalent dose, and in another ways, it is 1 sievert is equal to 1 gray. And if we see this thing, that how much radiation is allowed to us. So we have ample of patients. We have so many millions of patients, and many specialties can do endovascular, say it neurology, radiology, neurosurgeon, whosoever. So we have, and this is good, that this is important that we can save ourselves. So if we see that we have category A workers, B workers, A workers are where they are potentially exposed to more than 6 millisievert per year effective dose, and more than 15 millisievert for the lens. Whereas in two categories, it is less than 6 and less than 15. And the annual limit which is allowed to whole bodies, 20 millisievert to the category A workers, and 500 for the skin, and 20 millisievert is for the lens. So we are exposed to two complications, that is stochastic, which are randomly can happen to anybody, and there is no limitation of the dose of the radiation. Even the smallest dose radiation can do harm. Like malignancies, we have seen glioblastomas happening, and thyroid cancer, which is very common. Indeterministic, where they can be reverted, like skin lesions and lens opacities. So if we see this chart, for 2 weeks exposure of 5 gray can lead to transient erythema of the skin. As the duration of exposure increases to 8 weeks, and of course if duration is increasing, the dose will also increase. So if it reaches to 10 grays, and with time maybe say 40 weeks, and the dose is increasing to 50 gray, you can have permanent changes like desquamation, and even more, then you can have dermal necrosis, atrophy of the dermal atrophy, and the radiation-induced telangiectasias also. So how can you protect yourself? So LRA is as low as reasonably achievable. So what all things you can do to get this LRA? So if you see the machine, any C-arm or any X-ray generating machine, whether it's lab or C-arm, this is the thing where the X-rays are generated. This is the intensifier or the receiver. So the X-rays are released from here. They are converted into light photons, and they impinge on the photocathode of this intensifier. And this will release the electron. So now you have electron-photon complex. And they will be accelerated in this tube across a vacuum, and this will give you amplified image. And that is how you get the image on the monitor. So what LRA says, one is time, distance, and shielding. That is how you can protect yourself. So if you see this, which I showed in the last slide also, last presentation, that if you see this at the end of the procedure, you'll be scared how much was the K value was allowed to you, and how much you received at the end. How much was the fluoroscopic time? Imagine 140 minutes. So more complex procedures, more radiation. So you need to check this all. It is not only X-ray tube machine is giving you radiation, it is a scattering dose is also there. That is, your patient is receiving the radiation and patient is also scattering the radiation. So the operator is getting double dose. One dose is from the machine and another dose is from the patient itself. So beam on time, exposure duration should be minimum, and when you are prepared, means your view is prepared, everything is, machine is positioned, parked properly, then only you switch on your pedal. Then many a times I have seen people very enthusiastic, they'll stand very close to the machine. If you decrease the distance from the source, your radiation exposure is also decreased. So stay back from the radiation source. Then as you magnify the image, your radiation exposure is again more. So when you are magnifying, means your size of the film is decreasing, your exposure is 7 times more than the small views. Then again, fluoro or cine mode. Cine mode gives 6 times more. What we use usually the cine mode. So if your aneurysm or your things are bigger, you can switch to and you have put one coil. You can switch to the cine mode rather than you can switch to the fluoro mode rather than the cine mode. That will decrease the radiation dose. Then angulation. More angulation you are making, more exposure is happening, because it is spreading, scattering all around the field, which on angulation, this X-ray beams are getting. So this is highest angulation, highest deep view that will give you the angulation, because you're standing always on the right side, and LOA view is scattering the radiation more. So LOA view will give you more radiation. Then again, your machine, the intensifier should be as low as to the patient. Less than 1 meter is best, where you are getting the less radiations. Then these are the cases where you should be careful, pediatric young patients, then of course children, then patients weighing less than 10 kg or more than 125 kg, pregnant women of course, and procedures where you anticipate that you are going to have more radiations, complex anatomy, complex procedures, long procedures, AVMs where you are cannulating many vessels, then repeated exposure to same body within 60 days again, that you are exposing yourself as well as the patient to the repeat radiation dose. So if we say pulse, what should be the pulse, generated pulse per second? Our eyes can pick up only up to 12 pulses per second. So there is no need to increase the pulse beyond 12. So that class 1 recommendation says that pulse rate should be as low as possible, that is 7.7 pulses per second. That is good enough. And you can increase the pulse if you want to see the fistulous communication. Otherwise, slow pulse, 2 or 3 pulses is good enough for the aneurysms and all. Then again, you can use this kind of pointer in your machine and move the machine using these pointers so that you get the radiation-free positioning of the patient in relation to the C-arm. You can use the previously stored images where you can use them for your next step. So, if I say, these are all things which are very, very essential components of the lab. The lead glass should be less than 0.75 millimeter lead. More than 0.75, then of course dosimeter. In fact, you'll be many a times you feel that what is the need of dosimeter. Your RSO keeps sending you the message, send your dosimeter, and we do not care about sending the dosimeter also. So once I sent my dosimeter and it was found that it was very high dose. I was surprised that I have not gone to the X-rays for this month. How come I had put my dosimeter onto the lad coat rather than inside the lad coat. So people say that ideally you should have 2 dosimeters, one inside your apron, one outside the apron. One at the level of even eye to protect your lenses to get the cataract or lens opacities. Then gloves, of course, it is again 1C or 2C recommendations are there to use a gloves or not. Thyroid collar, yes, big yes. And your apron should be more than 0.35 lead thickness or lead free, whatever, and ideally double breast. When you have double breast, then you have at the waist level, you have the belt. Even if you have single breast, single length, but double breast, you can always have a belt at the level of the waist that will reduce the weight of your lead gown. And shield drapes are there. In Japan, they are using shield drapes, but they are not using thyroid collar. So that is how they have done the studies where if you are using the shield drapes which cover the intensifier area, so that is one of the way. Headgears, yes, very big yes, which normally we do not consider. So there are class 1 recommendations for short time per run, lowest frame rate and least number of acquisition possible. Then preoperative planning, they again class 1C level recommendations that you should do preoperative planning, which view, what view, and everything should be done so that that decreases the radiation exposure. Collimation, definitely, that will reduce drastically. You have collimation both in C-arm as well as your lab. Then collimation again, class B, 1B evidences that collimation decreases exposure. Now TLD badge, as I said, every person should get the TLD badge. Every person, whether resident is there for 3 years or any staff fellow is there for 1 or 2 years, you should have the TLD badge. You have RSOs in every hospital. Even if you do not have intervention, means gamma knife or Linek and all, which in fact in our hospital we do not have because we have associated Loknayak hospital where they do it. So, but your department has got CT and all. There is RSO grade 1 level. They will do everything for you. So every staff, irrespective of their level, even the Safai Karamchari should also have the TLD badge because we all are exposed not only to these radiation, the radiation outside our workplace as well in the atmosphere. So what we have 2 types of TLD badges. TLD is thermoluminescent dosimeter, and we have passive. Passive means after 2 or 3 months they ask you to give this and it goes to the AERB. From there it comes back, your report comes back, and then you know whether you are allowed to go in the lab or not. You have another active. Active ones, they will give you continuous measure of, during the procedure also that will give you continuous measure. So there are class 1 recommendations also that you should use ideally 2 radiation dosimeters. Then we have in our India also we have the body AERB, that Atomic Energy Radiation Board, which governs, which rules all our radiation laws, and internationally also you have ICRP. As I said, pulse rate should be less. Now this is a chaotic lab. This is an interactive slide. Now tell me, what is chaos here in this lab? What is the chaos in this lab? Anybody, resident level. What is the chaos in this lab? There are 3 pictures, which is totally chaotic. And actually we work in these situations. Every time we work in these situations. Being the senior, being the observer, being sitting in the room, you should see these happenings. All 4 people are there exposed to the radiation. No one has the cap, right? This is the operator who is operating the machine. He is also exposed to the radiation. Staff is doing nothing, exposed to the radiation. This assistant is doing nothing, exposed to the radiation. This technician, no thyroid collar, no head gear. Then this lead, it is away from the head. So all this is chaotic lab. At least we can work at these levels that your staff is behind this LED screen. So whenever you are asking for the lab, you ask for the 2-3 screens, LED screens, which will protect you, which will protect your anesthetists. They are vulnerable to get higher doses of radiation. So they cannot be all the time in the console room, but they have to be inside the lab also. So there should be 2-3 LED this thing. And you won't believe, your OTs are designed in such a way that you have 9 centimeters of thickness of the wall. Otherwise you cannot use do your spine cases also. So you can have lead walls, thickness of the wall of the OT, they are designed in such a way that even any time the AERB can come and do the inspection. Even those people who do not have lab, those people who are doing only for spine, they also can be caught and their lab can be stopped there. Even the C-arm can be stopped functioning by the AERB. So if you make your staff, your assistant outside this screen, you can reduce the dose to them. You bring this screen close to the head. This is tall guy. So this screen has to be closer to his head. So your exposure is decreasing to the head. Then you are using the cap. All these things are very essential, small steps, but very essential. And I would suggest Vikas, if he has time, he can gift all the people a cap, because we do not normally use the lead cap, which is very, very essential, not only for endovascular procedures, for spine as well. So these are very small things, but we can reduce, cut down the doses. At least this is not only the machine which is, we are decreasing the scattering dose also. So ionizing radiations, if you are using, they should be used on 3 principles. Use of radiation should do more good than harm. We should be able to justify the procedures. Many a times we want to increase the number of the cases and we subject them for the DSA, just go and do the DSA. But we never think that how much radiation we are going to get, how much we are giving to all, and what extra benefit you are getting. You should be very careful, clear. Radiation doses should be kept as low as minimally achievable, and dose should not exceed the appropriate limits. So it is not the responsibility of operator, it is a joint responsibility of everybody, that even the patient should not get the high amount of radiation acceptable dose. So these are the references from where I have taken. Thank you.
This is very enlightening talk that I have heard in recent times, and very important for all the people who are working with radiation exposure. One interesting thing that I have noted is in the theater, one person is wearing the lead shield and 3-4 people are standing behind them. I think many of you must have seen that. So that is again dangerous. Any questions on this topic? Yeah, please. Batu.
Very nice and very important topic you have given a lecture on. So we know about all sort of protective measures. Have you come across the protection for the feet, shoes, radiation protection shoes?
No, not
because
yet.
See, we are covering everything.
Yes, you're right. But of course not for feet, but below knee up to feet we can do, but not feet. Yeah, we can think on that.
What happens if you don't wear head thing?
Yeah, the glioblastomas has been reported.
Just to add on, there is a new device in the market, protective shield, that is called, I suggest to Vikas, that is called Rampart glass system that we just bought. So it is in the market for past couple of years, but it's a costly thing. So if you are performing DSAs on regular basis, so it's a sort of protection device, a lead shielding device, and you can actually increase the surface area that is that you can cover. So it is floor mounted. You can increase the height of the glass ceiling. You can fold it, and it can come before you like a C. So it's very good device, and but it's costly. It's cost like 1 CR. So if you can buy it, that Rampart glass system, you should go for it. We just bought it. Thank you.
Yeah, good. I think cost doesn't matter when we are buying 9 CR machine and 9 or 11 CR, 1 CR adding is protecting so many people.
This week, I think, any other comments, questions? No. We come to the end of this session, important session, a lot of discussion, a lot of insights. I would like to thank all the speakers and all my chairpersons and the moderators of the dais. Thank you very much.
Thank you, sir. With this, we conclude our first session. Thank you to all the chairpersons and moderators, and thank you all speakers for giving us this wonderful session. We'll move on to session 2. Now, this is a microvascular session. So I will like to call upon the chairpersons for this session. So I'll call upon Dr. Rajiv Ranjan sir, Dr. Rohit Kumar sir, and Dr. Anand Prakash sir to kindly take their seat on the dais. The moderators for this session will be Dr. S.M. Rauturgi sir, Professor Dr. Sharad Pandey sir and Dr. Ravindrakumar.
Already we are late, so our next speaker is Paritosh Pandey sir. He will talk in microvascular anastomosis, tips and tricks. Sir, please.
Yeah. So we'll be a little brief because we are short of time and things. So revascularization in cerebrovascular surgery, again, as with most of the open cerebrovascular surgery, the indications have become very, very few. But it is a very good tool to have in your armamentarium because even if all the aneurysms, most aneurysms are coiled, aneurysms which require bypass will remain, and that requires. So there are two types of vascularization: low flow bypass and then high flow, which Vatuk will say. So flow augmentation, we have low flow bypass. This is the majority of the indication. And then flow replacement, sorry about the typo. And this is for aneurysms and other things. And there are three types of microvascular anastomosis. One is end-to-end, which a large number of plastic surgeons will do. And that is one of the most important anastomosis that the plastic surgeons do. What we do most of the times is end-to-side anastomosis, which is almost 95% of our practice. And then there is another anastomosis called side-to-side, which I'll show you once. So these days, the present indication, 95% of them are ischemic diseases, and out of that, 90% is moya, at least in my practice. Rest is carotid occlusion, atherosclerosis, dissections, and things like that. Very, very few high flow bypasses are being done, not just in India, but world over because of the rapid availability of flow diverters. And of course, you can do a STMCA bypass for very complex aneurysm as insurance bypass if branch vessel is coming out of the aneurysm and other things. And others which were common previously, like occipital artery pica bypass, STA, SCA bypass, or pica bypass, all those things have become extremely rare in even very, very busy bypass centers. So 95% of the times we are just doing STMCA bypass for moya disease, which we do combined revascularization. So this is one of the 38-year-old lady who had multiple TIAs. SPECT was done. This is typical finding, and we have become a fairly decent center of bypass. So there are many steps. First step is harvesting of the STA. And then we don't disconnect the STA till we make a craniotomy and see that there is a sizable MCA which is there. Preparation of the donor vessel, so the distal end is completely denuded. Then preparation of the recipient vessel. You take a large MCA vessel on the surface itself, which should be generally in the middle of the field. Then we cut the STA in an oblique manner. And then the procedure is to do heel stitch, toe stitch, and then both sides together, and then do an ICG. So these are basically the various steps, and this is how it is done. So this is the MCA here, and this is the STA. So first you take what we call as a toe stitch. So what we do is we generally put both heel and toe stitch before hand itself. So this is the toe stitch on one end of the MCA, and then this is the heel stitch on the other end of to anchor these two. And once it is anchored, it is just a matter of putting 3 or 4 stitches between the STA and MC on both sides. In adults, you can use combined running stitches. In children, generally we don't do running stitches. These are 10O ethylon sutures, 3313 or 3314 by Johnson & Johnson, which gives quite a good grip to things and has knots very well. And these basically your main instruments are scissor and jeweler forceps. So with 2 jeweler forceps, you can get the entire anastomosis done. So that side we did running stitches, and probably this side we again go ahead and we are doing interrupted sutures. Most of the times, most people do interrupted sutures. Sometimes because of the time itself, we do running stitches, and that also works fine in the things. So this is how it is done. We will do it in lab after some time. So after putting adequate number of sutures, we take off the distal first and the proximal, and then again we do the anastomosis itself. So this is generally does not bleed. If it bleeds, you can put one more stitch, and that suffices here. And at the end of the day, this is the revascularization that you get after 6 months. You see that there is a very large increase in the diameter of the STA. Sometimes we do it for aneurysm. So this is a rare patient which we did a few years back. A 19-year-old boy. His only problem was he was very tall, and someone said that you may have Marfan syndrome. So he was investigated, and a CT scan was done which showed this. So this is an unruptured large MC aneurysm, partially calcified, and this is the CT angiogram here. So this patient does not have an endovascular solution here, and will not have it. So there is a large sac which is partially thrombosed, heavily calcified, and both aneurysms, both MCAs are coming out of the thing. So this is the angiography that we did, and this was referred from somewhere else. The interventionist wanted to do a flow diverter, but it could not pass it. You can see here. So there is both MCAs are coming out of the aneurysm itself. So what we did was we went ahead and opened up the vessel. All this is aneurysm here, and these are the 2 vessels which are coming out. And so this is one vessel, and then there is another vessel which is coming out of here. So this is the middle cerebral artery, and all this is aneurysm here. And this is a 19-year-old boy, completely asymptomatic. So what we did first was harvest the STA and did an STMCA bypass into this branch. So regular STMCA bypass was done. That I will skip here. Nothing much. So after the STMCA bypass was done, the last sutures are being placed. And then we do an ICG after taking out the proximal one. So this is gone, and yeah. So ICG is filling quite well. It is filling other branches as well. Unfortunately, we could not enter either the proximal or the distal branch of the MCA. It was so heavily calcified that I would have to open up the blood vessel. So I just left it at that. And the theory was that if we provide another way for the blood to flow, then this will thrombose, and that is unfortunately what happened. So this is what was done. He was okay, and fortunately that is what was happened after 6 months. The aneurysm is completely thrombosed, and the STMCA bypass is functioning quite well and providing the branches to this thing. And there's the angiogram of this thing. Sorry, there's the STMCA bypass, which is filling up quite well. We can do in situ bypass as well. This is a patient, I don't have the video, but in this case what I did was we excised the inferior branch and implanted into the superior branch, and then it becomes a very good aneurysm to clip here. And then pica bypass, this is the last pica bypass I had done almost 10 years back. There is very little thing. Now if we have to treat it, we'll just put a flow diverter here and there should be nothing. That time we thought that we will do something else. So this is a dissecting aneurysm of the pica. Pica is arising from. So we went ahead and did a pica bypass. There's a more complicated bypass for this. We open up both sides and then the inferior wall is sutured first with running stitches. First we go ahead and anchor both of them. And what we have to always remember in this case is that we have to go outside in, inside out. So all the knots have to be outside the blood vessel and not inside the blood vessel. So first we go ahead and do the inferior bit, and then we suture the superior bit. And once we do the superior bit, it becomes like H. And then we can sacrifice the pica and coil that aneurysm after sacrificing the pica itself. But as I said, these are very rare conditions. Sometimes, twice we have done OA pica bypass as well. But those things again are very rare with the availability of modern endovascular armamentarium. So we remove all the 4 clips, and this is how a bypass should be. And when we do an ICG, there is bypass is functioning, and hence you can go ahead and sacrifice this thing. So our experience is these many, and more importantly, I think bypass surgery, when I was doing a residency, Dr. Suzuki had come to All India Institute of Medical Sciences, and absolutely nobody in India, or hardly 2 or 3 centers, were doing bypass at that point of time. And now I'm sure there are at least 50 centers, if not more, who are performing bypasses for different indications, and very, very successfully. Microvascular anastomosis courses are held very regularly in the country. NSI does it, AIIMS does it, NIMHANS does it. NIMHANS course, which Dr. Nupur does, is as good as most of the microvascular courses done abroad. And I urge most of the residents to go and spend 4 or 5 days and then learn this technique here. And there is a very healthy, widespread interest among surgeons to learn these techniques. So STMC bypass is the workhorse. Different varieties of bypasses are used in different conditions. And this is a good armamentarium to have in your thing. Thank you very much.
Very nice presentation, sir. Now topic is open for discussion. If anyone asks, only 1 or 2 questions are allowed.
Can we do it without intracranial Doppler?
Yeah, I never use a Doppler. ICG is very good.
Only through ICG?
Yeah. We used to use Doppler before we had ICG.
And how to identify the STA?
Just palpate. You can
just
get it.
Through the palpation.
Again, you can use a Doppler outside. Many people use it. I just palpate. I mean, it's an artery. It will show itself.
Okay.
Yeah. Yeah. Right. Thank you.
Dr. Pritesh.
Sir.
Is there any role of putting a graft anywhere nowadays between the 2 blood vessels?
Yeah. So
grafting.
So the graft, the high flow bypasses has a graft. And I think that is the next talk that Dr. Batuk will say. So the grafts are there. Very rarely you can put a very small graft between while doing, so that if there is a very complicated MC aneurysm, you can cut the thing, and then between those you can put a very small radial artery graft. But yeah, but nowadays Dr. Batuk will show that there is a radial artery graft and saphenous graft and all these other things. Thanks.
Now I invite our next speaker, Dr. Batuk Deora, who is Professor, Department of Neurosurgery at LTM Medical College in Sion Hospital, Mumbai. I have worked under him and I know he is a fantastic surgeon.
Thank you, Chairpersons. Thank you, Anand. So we are going to talk about, in the microvascular sessions, we are going to talk about the low flow as well as the high flow. So, so many things has been told about the low flow bypass. Just to refresh about the revascularization. When we talk about the revascularization, it is the restoration of the blood flow. And if we see the history, it was almost started 80 years back. But still, we are having a limited options in the form of STM, say bypass or some sort of a synangiosis or the high flow bypasses. So in today's era, cerebral revascularization is being performed for only 3 or 4 indications. Like one and commonest is the moya disease. Second, it's not so much like there is no good class evidence with the arterial narrowing resulting in the TIA or a stroke, especially for the middle cerebral artery. Many cases of the large and giant aneurysm being treated with the high flow bypass, but with the advancement of the endovascular treatment, more and more are going for the endovascular treatment, and very rarely about the skull-based tumors with the major artery involvement. So we have a 2 type of revascularization, direct and indirect. So I will be talking mainly about the direct, where we vessel to vessel anastomosis between the recipient and the donor artery. We have a recipient and a donor artery at the 2 different indications, one for the moya disease and one for the giant and large aneurysms. So when we talk about the revascularization, we always talk about whether it's a direct, indirect, whether what is a donor artery, what is a conduit, what is a recipient, and most important thing is the technique of anastomosis. So donor vessels, we have a superficial temporal artery that is being commonly used, very rarely middle meningeal arteries, and in an occasional case of occipital artery. Conduit, commonly we use is a radial artery or a saphenous venous graft. And see the difference between the low flow and the high flow is on the basis of the flow. If the flow is less than 50 ml per minute, that is called a low flow, and more than 50, that is called a high flow bypass. Radial artery provides a flow of around 50 to 150 ml per minute, while the saphenous provides around 100 to 250 ml per minute because of the wide bore. So there are some difference of the between the arterial graft and the venous graft. Artery, commonly we use the radial, the most spasmogenic, but having a good patency rate. And many times the length is an issue. In compared to the venous, easily available, there is a less chance of the spasmogeny, but the main problem is the luminal discrepancy. So as I mentioned about the depending on the flow, we define the high flow and the low flow. So recipient artery mainly we use as a superficial temporal superficial temporal artery, and anastomosis technique commonly we use a hands-on technique, though the laser-based technique is available, but it is relatively costly. So the important principle is while planning for anastomosis, either low or high, one has to have a fish mouthing of the graft and before the anastomosis. Teardrop arteriotomy of the recipient artery. One has to ensure there is no air in a graft, back bleeding, and that has to be ensured with the back bleeding and the flushing. And as we have discussed, patency can be judged by either a Doppler or angiogram. And most of the time we put a bone flap back. So Paritosh has shown low flow bypass in the form of the STM bypass that is commonly performed especially in the adults age more than the some pediatric patients more than 5 years of age, and where we put a superficial temporal artery, dissect the superficial temporal artery first, and then do the temporal craniotomy, and then anastomose the superficial temporal artery with the angular branch of the middle cerebral artery. So this is the intraoperative, I can't see the, anyway, this is the intraoperative clinical photograph showing the superficial temporal to middle cerebral artery anastomosis. In case of a high flow bypass, we also take an additional incision in the neck to dissect the internal carotid artery. So always the cranial anastomosis first, then the neck anastomosis. And we, as I mentioned, we use either saphenous venous graft or the radial artery graft, like shown in these pictures. These are the prerequisite, very good quality micro needle holder and the micro scissor along with the jewel forceps, as well as the microvascular anastomosis clamp. And nowadays we are using a mini aneurysm temporary clips for this purpose. This is a very good cartoon showing how, before you do any sort of anastomosis, you always have to remove the adventitia for a millimeter or two, if possible. And this cartoon shows how you hold the needle holder and how you pass the needle through the arterial end with the help of this Jewell's forceps or passing the Jewell's forceps through the lumen or holding with the tip of the Jewell's forceps. So the techniques is knot technique is simple. We usually take 3 knots minimal. And anastomosis has to be watertight and with the least number of sutures. Suture has to be perpendicular and with the equidistance. And the maximum minimize the patency by avoiding or constriction of the suturing wall. And adventitia, as I mentioned, remove 1 or 2 millimeter of adventitia. We can dilate the vessel before anastomosis 1.5 times and always take a full thickness suture, and interrupted suture are better than the continuous sutures. So this is actually the video. I'm skipping this video, but I will share this case. A 35-year male who presented with the 2 episodes of a TIA and 1 episode of left-sided TIA. You can see the intensity changes on MRI images. So when patient came to us, there was a complete occlusion of the middle cerebral artery on the right side. However, patient was having a good power. And we did a DSA showing almost a 90% stenosis of the middle cerebral artery. So this patient was dual antiplatelet medication, and in spite of the dual antiplatelet medications, he was developing a symptom. So we decided we'll plan for a STMC bypass for this patient. So the procedure is same, like you make a vertical incision over the superficial temporal artery. I can't have a control here, video control. So once you dissect the superficial temporal artery, then make the craniotomy, and then one has to decide and identify the angular artery. The most important thing is there are many small arterial perforators where you are exactly doing the bypass. So one has to be careful and identify that small perforator and coagulate. We can coagulate and cut 2 or 3 perforators. Otherwise, it's extremely difficult to isolate the vessel from the brain parenchyma and do the anastomosis. Rest of the steps, I think Paritosh has already shown. So again, like we do the same procedure, and I always keep the Doppler ready because I use a vascular Doppler a lot, but also we have a facility for IC angiogram. So once we confirm this thing, with the Doppler, we always see the flow through the anastomotic side. So after finishing the anastomosis, I always put a proximal clip, at least we'll confirm that there's a flow is coming from the superficial artery and going into the distal branch of the middle cerebral artery. So at least always you confirm there is a patency of the graft. So this is a postoperative angiogram showing a patent anastomosis, and you can see this is the AP and the lateral images. This is another case. He was a 45-year male, similar symptoms in spite of the medication. Usually in my practice, nowadays we see a lot of case of middle cerebral artery stenosis, and we do not go for this sort of procedures in all the patients. Those patients having a significant stenosis and they develop a symptom in spite of a regular course of a dual antiplatelet medication, then we plan for a surgery in this patient. So this patient was having again the right-sided middle cerebral artery stenosis, M1 segment. And you can see this is a 3D rotational angiogram to understand the better. Suppose you're planning for the stent procedure, you should have a better understanding. In these patients, we have discussed about the intracranial stent, but the relative was not willing for any sort of a risk associated with the procedures, and finally we decided we will go for the bypass in this patient, and we did a bypass. This is the post-operative angiogram showing the patent bypass. You can see this is the bypass here, and there's a retrograde flow in the middle cerebral artery. So if you can see, this is again the rotational angiogram showing the patent bypass and significant flow over a period of time. This vessel's middle cerebral artery completely blocked, and the circulation is entirely taken by the middle cerebral artery STMC bypass. So this is the craniotomy site. Here I am showing a case of sort of a low flow bypass in a posterior circulation. This patient was having a vertebral pica junction aneurysm, and actually I was not operating, but I was called when there was a sudden avulsion of the pica from the vertebral artery, and ultimately to save the to prevent the hemorrhagic shock, we need to actually clip the vertebral artery. So after that, we dissected out the occipital artery and did a occipital artery to pica anastomosis in this patient. This was the end-to-end anastomosis, the end-to-side anastomosis with the pica and the occipital artery. Now coming to the high flow bypass is when the flow is flow required is more, means you are entire circulation you are sacrificing either for the aneurysms or for the tumors. Then we need to have a high flow bypass in a given case. So this patient was a 40-year female patient having a left facial pain, and she had a sensory symptoms. She waited almost like a year before she came to us, and you can see there was a large mass lesion in the left cavernous sinus, and here you can see this, there was a wide neck sort of abnormal looking outpouching from the pictus in the cavernous aneurysm, cavernous ICA. In these patients we planned for we did the balloon occlusion test, but patient failed, and ultimately we did a high flow bypass in this patient. So when we do the high flow bypass, we always do the first craniotomy and the cranial anastomosis first, and then the neck anastomosis. I usually prefer a saphenous venous graft because I am very much concerned about the radial, and I had a problem in one of the patients. So I always use always a saphenous venous graft in compared to the radial artery. So once you need to have a wide Sylvian Fisher dissection, identify the recipient artery, and then you start the you first bring the graft. Just a minute, I will just show you how to bring the graft. So usually we bring the graft from the subzygomatic plane. You pass the spensal artery from above and bring into the neck, and just with the help of the chest tube, we bring the graft into the cranial end. Then the anastomosis is performed. Usually we perform with the 9-0 ethylone taper point in an interrupted manner. So here you can see the arteriotomy. Arteriotomy, there are various options, but I prefer the arteriotomy with a sharp tip needle. Many people use micro scissors, that is now Kameyaki micro scissor is available, but I always prefer a needle for this arteriotomy. So here we first do the posterior wall, and then then the entry wall. So once you confirm there is a retrograde flow inside the graft, because there are valves, so there will not be flow coming to the neck, and then subsequently you do the neck anastomosis. Here we use external carotid artery, and the suture material is a 70 proline, again in the interrupted manner. So this is the anastomosis in the neck. And finally, you can see the flow, and we always confirm the flow with the ICG. In these patients, we did a post-op angiogram, and this patient I have not directly ligated the internal carotid artery. This is the post-op angiogram showing the pattern graft, and still you can see the aneurysm. So in this patient, I did a ICA ligation after 7 days, confirming everything, and you can see this is the patency of the flow. So this is a main concern, but the patient was having a very good flow from this anastomosis. This is the post-operative CT angiogram after ligation of the internal carotid artery in the neck, complete disappearance of the aneurysm. This was again interesting case, 16-year female, right-sided eye pain and severe headache, followed by the complete ophthalmoplegia with a visual impairment. CT was reported as a mass lesion in the sphenoid. But when we did a DSA, we found there was some sort of aneurysms, aneurysmal outpouching arising from the pictus carotid. So this was a giant pictus cavernous aneurysm on the right side. There was no cross flow, and there was you can see this AP lateral. And on the left side, the left ICA was almost completely hypoplastic. There was one of the branch that was supplying the supraclinoid ICA. So in these patients, we cannot sacrifice the ICA because there was no ICA flow, and there was some collateral from the ECA. So we decided this collateral is not sufficient for a young patient. So we did a high flow bypass for these patients. We were concerned about the outcome in terms of the vision and as well as the improvement in the ophthalmoplegia. However, I will just show these operative steps, like again the craniotomy first, the incision in the neck, and then we use a saphenous venous graft. So I will just skip this video again. Post-operatively, she had one episode of seizure on the third post-operative without any neurological deficit. But we did a DSA on the 7th day before the discharge. There was a complete patency of the graft where the good collaterals, ICA was ligated in the same setting. And this is the rotational angiogram, patient having a complete improvement in the vision as well as the ophthalmic symptoms. So I think with this I will conclude. Thank you.
Nice presentation, sir. You have wonderful experience. And have you, sir, any experience of post-operative leak in any case in high flow graft? Although you are doing post-op angiogram also. In any intra-op angiogram, in post-op cases, any leak in cases of high flow graft or graft?
I can hear you. If you can speak loudly.
Sir, any leak in your anastomosis after?
No, I have not seen a leak in either of these patients. Yes.
Okay. Thank you, sir. Thank you, sir. Nice presentation. And now, to any query from open? Dais is open. No queries. Thank you. Thank you
all. I would like to take this opportunity to felicitate the chairperson and the moderators for this session. Thank you, Chairperson and moderators. Now, with this, we conclude our second session about the microvascular. Now, we have successfully completed both endovascular and microvascular sessions. And now I have two announcements for which we have been waiting for. First is that we can break for lunch now. And second is that the persons who are willing to join the workshop for the microvascular and endovascular, you can kindly reach and meet Dr. Shivam on registration counter. So we will be given separate counters to avoid any congestion in one particular one. Thank you.